Right. Okay, guys. Is everyone here? Okay, turn your cameras on. I know some students. Okay, one student has a small issue with the camera. That's all right. Okay. So, welcome to the final class by me in this module. Today's topic, leukemia. Right now. Okay, let me share the screen. Anything at all you all know about the word leukemia, right? Just unmute and just talk.
Cancer of WBC.
Sorry, I did not hear. Okay, one person at a time. Shashank, what did you say?
Cancer of WBC.
Cancer of the
WBC.
WBC. Okay, excellent. Cancer of the WBC. Tharinda, what did you say?
I said the same thing.
Same thing, same thing. Okay, same thing. Right. So have any of you all studied leukemia in your universities? Have you all studied leukemia in your universities? Yes, yes. Okay, I see some people nodding their head. Guys, others, turn your cameras on. How has leukemia been, especially in your examinations? How have you found leukemia? Easy questions or difficult questions? Generally?
Not common, but difficult.
Not common, but difficult. Right. Excellent. The problem is, guys, even for me personally, so leukemia, today we will go into as much deep as we can. So this is, as you all said, a cancer of the blood cells, right? Specifically white blood cells. Here, there is so much. There is so much that we do not know, right? When you take medicine as a whole, there is so much that we do not know. You can go to whatever textbook you all prefer. You all will find so many empty spaces, blanks, right, that are not described, right? And on top of that, right, for MBBS, obviously we have very little that we need to know, right? For MBBS, the thing is, guys, because we don't know so much, it's difficult to make a nice understanding, a nice deep understanding of the subject, right? It's difficult to make a nice story. Imagine this is happening, then from this leads to this. Like that, it's a little bit difficult for leukemia, right? So today we will try our best. And the other issue is leukemia. Now I'm giving you all a small warning at the start, right? Leukemia, for me personally at least, it's a topic, guys, you can learn today. You can try your best to understand everything today. Tomorrow, right, you will jumble the concepts up, because there are 4 leukemias that we're going to talk about. They are very similar yet very different, right? You will understand when we are discussing today. So I'm warning you all, don't overthink today's topic, right? And fall deep underground. Okay, so let's go superficially. Whatever is required for our MBBS, we'll do. We'll try to understand as much as we can, right? I have used all the sources for today's lecture, right? So we'll give it our best, right? We'll see. Right, let me share the screen. Yeah, there we go. Right. And you all are correct. With regards to exams, guys, leukemia is not a very high yield topic. It's a relatively low yield topic. You will find only very few questions from leukemia. But the thing is, right, those few questions, if you don't remember the concepts, very difficult to get them right. Okay. So today we'll try our best. And towards the end, I will give you a summary, a fully 100% exam oriented summary, that if you know those 4, we are going to look at 4 slide cards. If you know those 4 slide cards, you're good to go for your exam, right? That I will give at the end. Right. So let's start. You all can see the screen? All good? Right? Right. Okay. Look at this, guys. So today's topic, leukemia. However you want to spell it. The British version is AE in the middle, and American is E, right? Anything, whichever is easier for you all. Leukemia, right? So as we said, guys, this is a cancer of the blood cells, specifically white blood cells. Now, when we say cancer of blood cells, right? Cancer or neoplasm of blood cells. We know just from the word cancer, we know there is going to be some sort of hyperproliferation of cells, correct? Hyperproliferation of cells. Now here, just like in multiple myeloma, guys, remember we talked about in multiple myeloma, there was a clonal expansion going on, right? These cells were hyperproliferating, they were making multiple copies of themselves. What type of clonal expansion was it? Do you all remember for multiple myeloma, what we discussed? Monoclonal, right? Monoclonal expansion. Here, guys, it is the same, right? For leukemias, the clonal expansion again is monoclonal. That means from one cell type, just from one cell type, they are going to start clonally expanding and hyperproliferating and giving rise to the issues, right? We will see what those cell types are, how they happen, right? Right. So before we dive deep into the topic, guys, we'll take a look at the classification of this blood cell cancer classification. To understand the classification, guys, we have to go back a little bit for our basic hematopoiesis. So here we will make. I have put the actual hematopoiesis diagram, guys, in your notes. We are going to make this a little bit simpler and make our own version of it so that it's more suited for our leukemia chapter, right? So just take a look at this, guys. You all will understand what I'm speaking about. So at the beginning, what do we have? We have a what we call a hematopoietic stem cell, right? Stem cell, right? You all can draw this. Take a full page and draw this, right? This is going to be our classification for today's class, right? The stem cell, guys, it's mainly going to in hematopoiesis. We have the first differentiation is going to be either myeloid or lymphoid, right? So we'll have some myeloid progenitors on one side, and on the other side, we'll have lymphoid. Now, what is the difference between them? How to recognize them? We'll talk about all of those, right? The markers and everything we are going to talk about today, right? Then, when we look at the myeloid series, guys, right? Take a different color and draw 4 large cells, guys. Draw something like this. Draw the same thing. No need to make any differences. So I can just copy and paste. You all also just draw the same thing. Right? Something like that. Right? This myeloid series, guys, mainly gives rise to 4 cell lineages, right? So we have erythroblasts, right? We have megakaryoblast, monoblast, right? And myeloblast. These are blast cells. These are the very first stage, right? In cell maturation, we call them blasts, right? Okay. Right. Then, now, in hematopoiesis, guys, what do you all know? As the cell matures, what happens to the cell size? Do cells become larger and larger and larger, or do they become smaller and smaller and smaller? What happens?
Small.
They become small as the cells divide and they mature, they become smaller. So now what we are going to do, we are not going to draw the exact next steps for all of these, guys. So we'll draw a dotted line somewhere like this, right? All of these ones will put dotted lines like that, and then we'll draw a little bit of a smaller cell, right? A little bit of a smaller cell, something like that, right? So you all can draw like that, right? Something like this. And for the myeloblast, guys, I want you all to draw 3, because we are going to see 3 coming out of that. Let me show you all what I mean. Something like this. This dotted line indicates there are other multiple divisions going on in between, which we are not going to draw. right? Like this. Right? And then the final one, guys, right? Y'all can draw the final ones. From the erythroblast, what do we get? We get the erythrocyte, right? Draw them smaller, right? We get the red blood cell, right? Reticulocyte and eventually erythrocyte, right? Then from the megakaryoblast, we get what we call the megakaryocyte, right? This is the guy who produces all the platelets, right? Produces the platelets. He's a little bit larger. Huh? Then we have from the monoblast, we have the monocyte, right? Something like that. Yeah. And then here we have the three coming out, right? One is with this multi-lobed nucleus. What is this? This is our neutrophil, right? Neutrophil. And then we have another one, right? With a lot of blue color sort of granules. This is what we call a basophil. Basophil. And then we have the other one with some pink granules, pinkish granules, right? These are our eosinophils, right? So what do we have? RBC, right? Megakaryocyte, monocyte, neutrophil, basophil, and eosinophil, right? So this is the basic maturation in our myeloid, lineage, myeloid cell lineages, right? These cells coming from the myeloblast, guys, specifically the neutrophils, basophils, and eosinophils. As a group, what do we call them? As a group, what do we call them? Neutrophils, these three. What do we call them? Granulocytes. Good. Just note that name. I will tell you all why that name is important, right? Later when we come to the other parts of this chapter. They are called granulocytes. Right. So that is the basic myeloid series. Then we'll come to the lymphoid series, right? Lymphoid, nothing too complex, right? We have two coming out of this, right? Okay, draw these two guys. Again, similar, but maybe I will change the color just to make it a little bit more clear. Right. These are what we call lymphoblasts. So we have a T lymphoblast, and we have a B lymphoblast. Now take note these blasts. Now if you can see, guys, even in the myeloid one, at the start we call them blast. Towards the end, what are we calling them? Site, right? So blast being transformed into sites, right? Take notice of these words. Right. Then again, like in the myeloid series, guys, we are not going to draw all the steps. So just we'll draw some dotted lines, right? There are 4 or 5 cell divisions going on, right? And eventually giving rise to a much smaller one, right? Right, something like this. And eventually what will happen? They give rise to the 2 final products, right? Which is we have, right, a T lymphocyte, right? And another one, B lymphocyte, right? Right. right? So this is our basic hematopoiesis. Then you all know B lymphocyte again can further differentiate, right? We've talked about plasma cell, right? Memory cells, all of those things, right? We are not going to talk about those today, right? Okay. Now look at this, guys. We are going to use this diagram, right, to classify our leukemias. You all are still drawing. Let me see. Right. Draw. Okay. Enough time. Uh, later. We'll draw later. Okay. Right. Look at this, guys. So how are we going to split this? Look at this, guys. The first thing, the classification, we are going to base it based on the time taken for the onset of the manifestation. So we can have either acute leukemias or chronic leukemias, right? This is the first step. How do we segregate that, guys? Look at this. From this hematopoietic system, right? Anything occurring within this first set, basically anything occurring within the blasts, right? Anything occurring within the blasts, we call these acute. Okay. Anything occurring within the blasts, we call them acute. So these are ones with rapid onset. These leukemias are of rapid onset, usually days to weeks and rarely months, right? Usually days to weeks, right? They will start manifesting, right? Then anything, guys, anything evolving from these, remember we drew dotted lines, so we don't know the exact place here, guys. We drew dotted lines because there can be multiple steps here, right? So in any of these multiple steps, but not the blasts, also not the completely mature sites, right? Not the blasts, not the completely differentiated sites, somewhere in between. If it's occurring, we call these chronic leukemias, right? These are chronic leukemias, slowly progressive diseases, usually can take many years to develop and to show manifestations, right? Sometimes 5-10 years, right? After initial exposure. We'll talk about the associated risk factors, right? Okay, so these are chronic, right? Now, what is actually happening here, guys? Now, you all can, we'll come back to this diagram. Leave this diagram on this page, right? Take an, just go to a side note. What is actually happening here, right? What did we say, guys? So initially, we have a stem cell, right? Stem cell. And this stem cell differentiates, right? Okay. And this is an immature cell. I'm first drawing the normal one, huh? And then it gets a little bit smaller, right? It gets a little bit more mature, and then finally the fully differentiated cell, which is going to be, so the fully differentiated one is mature and it is specialized, guys. So they have their own function. For example, RBC, it has its own function. Now what is going to happen, guys, right? In the leukemia, in the acute leukemias, now let's say, so we have this initial stage of cell, right? The blast, we have the blast. But what is happening, guys, due to some reason here, there is a road traffic block. You can draw it like a stop sign, right? Right, there is a board that says stop. Right, stop. Right. So at this very early stages, they lose their ability to differentiate, right? But what is the important thing? They lose their ability to differentiate, but retain their ability to replicate, right? Retain their ability to replicate. So what is happening, guys? Now it doesn't move further along, but these fellows start replicating, right? Monoclonally expanding. This is the issue here. This is the issue here. So these are blast cells increasing in number. So this is what we call an acute leukemia. Acute leukemia, right? Acute leukemia, right? Now, let's just take a look at some of the features of these cells, guys. These cells that are now monoclonally expanding in the acute leukemia, they are fully immature, guys, right? They are fully immature, right? They're blasts. They are what we call blasts, right? Functionality wise, what do you think, guys? Functionality. Now, an erythroblast versus an RBC. What do you think of the function? What do you think of the function? Can they do carrying oxygen, going to organs? Can you do all of that? Functionality, guys, 0%, right? Absolutely useless. Absolutely useless cells, right? 0%, right? And these guys, they grow very rapidly. This is why, very rapidly. This is why we call them acute leukemias, right? Right, later we'll talk about the manifestations, right? They crowd the bone marrow and what is going to happen, we'll talk about, right? Okay, right. Then now we'll take a look at in the very same diagram. Look at this, the chronic leukemia. What did we say, guys? Here, somewhere in the middle, not at the blast phase, somewhere in the middle, there is going to be a roadblock, right? So let's take this middle cell. Somewhere here, there is a stop sign, right? Let me copy the same stop sign and put it here. Okay, there we go. Stop sign there, right? So not at the blast phase and often not at the fully mature or specialized, somewhere in the middle, somewhere in the middle. So these guys now start accumulating, right? They start monoclonally proliferating, right? Now, let's take a look at some of their features, right? Some of their features. What do they look like? Look at this, guys. These are, now, what do you think about the maturity? Are they fully immature? Are they fully immature? No, not really, right? They are a little bit more mature, more mature. But are they fully differentiated? Are they fully differentiated? No, right? They are a bit more mature, but they are not fully differentiated. They are not the end products. They are not the end products, right? Then the other thing, what do you think in terms of resemblance? Resemblance of the differentiated cell. Resemblance of the differentiated cell. What do you think, guys? Do they resemble the fully differentiated better than the acute leukemias, or they are even worse? What do you think?
Better.
Better. Basically, what I'm asking is, guys, now if we take the erythroid lineage, right? In the chronic leukemias, the cells that are monoclonally proliferating, they will resemble RBCs a little bit more, right? Compared to an acute leukemia, right? So they are better in terms of resemblance of the final product. So if they are resembling better, what do you think about the functionality, guys? Functionality. Is it 0%? Is it 0%? What do you think? Functionality, not 0%. They are not definitely, they are not as efficient as the fully differentiated final last resulting cell. But their functionality is still a little bit better than in acute leukemias, right? A bit more, you can say, a bit more better, right? A bit more better, right? Okay, and therefore, guys, because the functionality is a little bit more better, right? Resemblance is a little bit more closer. Because of these features, these guys, right, are resulting in chronic form of leukemia. Why? They take longer to give rise to the manifestations, longer to give rise to the clinical effects, right? Because their functionality is a little bit better, right? Everyone understood this concept? Difference between acute and chronic leukemia, right? Okay. Right.
Prashan,
Yes.
all the cell, do the cell grow rapidly like the one in acute leukemia?
Sorry, I didn't get
For
you.
for acute leukemia, you wrote there, they grow very rapidly, right? The cells
Right.
grow very rapidly. Is it the same case in chronic leukemia?
No. They do not grow as rapidly as acute leukemias. Their growth is also very slow. Today we will see some genetic factors that are leading to the difference in the rates of growth and all of that. But chronic leukemias, they grow much more slowly, right? Much more slowly. So the clinical effects are also much. It takes a long time to develop, right? Acute leukemias, weeks to months. Days to weeks. Chronic leukemias, months to years. It takes months to years to develop. Okay. Right. So now we'll leave that side note behind. We'll come back to our hematopoietic diagram. Right. So we've discussed acute and chronic leukemias. The next way we are going to classify these guys is this. Take another color, preferentially a highlighter. Right. The other one we are going to classify is like this. Right. Draw a big line in the middle like that, right? Okay, a big line in the middle. So the next classification, guys, any leukemia originating on this side, on the lymphoid side, we call it a lymphoid leukemia. And sometimes we call them lymphocytic leukemias. I will tell you all the difference when we come to those names, the nomenclature. On this side, it's lymphoid, right? On anything on the left side, guys, we call them myeloid or myelogenous leukemias. Right? Okay. So now, when I say acute myelogenous leukemia, right? Can you all tell me where it is? I will name these places. 1, 2, 3, and 4. When I say acute myelogenous leukemia, where are we getting the cancer from? Where is the cancer originating from?
1.
1, right? Chronic lymphocytic leukemia. Where is the cancer originating from?
4.
4, right? 4. Excellent. Did you all understand? Guys, if you all understand this, the rest of the discussion becomes very easy, right? Very easy, very much easier. Okay. So try to keep this picture. Now this picture, I know even for me, just looking at it once does not help, right? So I have this diagram, big and nice in my book, right? So whenever I take a look at it, I remember. Okay. So keep this diagram, very important for your leukemias. Right. Now, once you have understood this, we can move on, right? Here, guys, look at this. So basically, what did we talk about up to now? We can split the leukemias, one into acute, the other one into chronic. And each one of those can be of myeloid, right? Or lymphoid, right? Myeloid. Okay. Okay. Now, look at this, guys. When it is acute and of the lymphoid side, we call it ALL, right? Here, guys, the middle L, the last L is leukemia. The first A is acute. The middle L, guys, we change the name a little just based on the origin of the cell. So here we call it acute lymphoblastic. Now you all know why we call it blastic, right? You all understand. So we call it acute lymphoblastic leukemia, right? Okay. Then when it is acute and from the myeloid side, we call it AML. That one, of course, nothing special. We call it acute myelogenous, right? Or some books call it myeloid, right? Same thing, same thing. Leukemia, right? Nothing special there. We'll come to this chronic side, the chronic and the lymphoid, side, right? This is what we call CLL. Now, what do you think? Here, should I call it chronic lymphoblastic leukemia? In the chronic one, go back to your diagram. Chronic, does it come from the blasts? No, right? So because of that, we just changed this middle one. We call it chronic lymphocytic leukemia, right? because it's not from the blast. It's not from the blasts. Okay. And then again, the myeloid one, guys, again, there are no different. CML, we call it chronic myelogenous, same thing, or myeloid in some books. Myelogenous leukemia. There we go. Right? Right? Same thing. Just note the change in this lymphoblastic versus lymphocytic when we are talking about acute and chronic. Okay? Acute and chronic. Right? Okay. Right. Now, once you have understood that, right, you come down. Okay. We'll take a look at the epidemiology a little bit, guys. The epidemiology of leukemia. This we are talking about all leukemias in common. Later, when we go to the specific types, we will mention who it is seen the most in. But in general, guys, in general, when we consider, write this down in general, that is important because there are some subtypes where we see a different epidemiology. In general, when we consider leukemias, adults have it more than children, right? In general, right? Adults suffer, adults get the acquire the disease more, right? Okay. Except, guys, you all can put a small point here, except ALL, right? Acute lymphoblastic leukemia. When we come to that topic, I will mention that, right? For now, just leave it there, except ALL, right? Then if we look at the age groups, guys, age groups, right? Newborns, that means 0 to about 14 years of age. That means from newborn to about early teenage years, right? Here, guys, the most common one we see is this ALL, acute lymphoblastic leukemia, right? Then around the ages of 40 to 60, we see the myeloid ones, AML or CML, right? The median age of presentation is about 40 to 60 years of age, right? Then when it is greater than 65, guys, the most common one we see is CLL, the chronic lymphocytic type, right? So the myeloids are in the middle, the lymphoids are on the top and the bottom, right? Okay, now why did I give you all this, right? Most of the time, right? Majority, 95% of the time in question stems, guys, right? They will adhere to this, right? Because why? Leukemia is already, examiners know it's a difficult diagnosis to make, right? So they are trying to help you all however they can. So most of the questions that I have come across, almost all of them, they adhere to this. They adhere to this, right? So keep this in your mind, right? Okay, right. So that's the epidemiology. Now, let's dive a little bit deeper and see what is going on here, guys. What is giving rise to this? We'll look at the pathophysiology, right? Now, the important thing, right? As I said at the start, we do not know so much, right? But we'll see, right? Look at this. We'll start from the very basic, guys. If we take a blood vessel, right? Inside the blood vessel, there are multiple different, within the blood, there are multiple different types of cells. So we have our RPCs, right? We have our WBCs, white blood cells, right? And then what we have our platelets, right? We have platelets, right? WBCs, we further have different types, neutrophils, basophils, eosinophils, all of these are there. Now these blood cells, where were they made, guys? They are not made in the blood, no. They were made in the bone marrow. So they came from a bone, right, into the blood, right? Specifically, guys, in the bone marrow, right? You all know, it's in the somewhere here, no, in the center, no. If we take a cross section, right? If we take a cross section from a bone like this, what will it look like, guys? Basically, right? In the middle, we will see this hollow space. Within this hollow space holds the bone marrow, and that is where all these blood cells are being produced, right? Blood cells are being produced, right? Okay. Now, what happens in leukemia, guys? In leukemia, due to some cause, we'll talk about the etiological, we'll talk about the risk factors and all of that. Due to certain events, right? When we have a leukemia, what happens, guys? Initially, the cell production rates start increasing, and in the bone marrow, right, you have rapid and uncontrolled cell divisions, cell proliferations. Again, remember, monoclonal in nature, right? And they are going to, you're going to see something like this. Look at this. This bone marrow is now full of cells, right? Right? Rapid, uncontrolled cell division, right? And these cells, what do you think? Are they fully functioning cells? Are they fully functional cells? Definitely not as much as the very well differentiated final end product, right? They can be either functionality 0, depending on the type of leukemia, or they can have some functionality to a certain extent, but definitely not 100% functionality, right? What is going to happen, guys, due to this, will dysfunctional is not a good word. We'll say not properly functioning cells, not properly functioning cells, because we cannot use the word dysfunctional, guys, because they are not completely dysfunctional, not all of them at least, right? Okay, not properly functioning cells, when they start increasing in number, right, increase in number, what is going to happen, guys? Now bone marrow, you all already know, this is a very compact space, right? Bone marrow is a compact space. So one thing, these cells, they take up space, or they occupy space, right, within the bone marrow, right? The other thing, right, the bone marrow nutrition, guys, we have limited resources, right? We have limited resources. So what are these guys going to do? They are going to take up a majority of the nutrition, right? Okay, majority of the nutrition. Now, when they take up space and majority of the nutrition, now these are monoclonal one, right? One cell goes crazy and starts proliferating. So because of that, what do you think happens to the other healthy cells now? What is going to happen? Healthy cells start depleting in number. Healthy cells start, why? No space, no nutrition. No space, no nutrition. So healthy cells start dropping in number, right? Okay, this is going to give rise to what we call marrow failure, guys. Marrow failure, right? Marrow failure, we can see it manifesting in many forms. So when the healthy RBC is reduced, anemia. When the neutrophils reduce, neutropenia, frequent infections, right? Thrombocytopenia, all of these things. We've talked about all of those, you all know already. So for now, just keep it written down there, marrow failure, right? Marrow failure, basically anemia, neutropenia, thrombocytopenia. These are the main three ones, guys, right? Okay, right. Then look at this. The next thing I want you all to know, as these numbers are expanding within the bone marrow and its limited space, the surrounding bone, right, and the inner cortical bone, guys, these ones have nerve endings. So these nerve endings start getting stimulated, right? As there is a clonal expansion of these masses, these cellular masses, they are crowding the bone marrow and they are just expanding and expanding. They are going to start compressing against nerve endings in the bone itself, right? Within the bone itself. And this is going to give rise to what we call bone pain, guys. Bone pain, right? So patients, what they usually say is not from the muscle, right? The pain is coming from somewhere deep inside, right? A dull, aching type of pain, right? Bone pain. This is what we call bone pain. This is particularly in leukemia, guys. Now, bone pain can manifest in a number of disorders. In leukemia, particularly, right? I want you all to know, in the sternum, in the ribs, right? Hips and legs, guys, especially tibia, tibia, right? These are the main one is the sternum. I don't want you all to forget sternum, right? Remember sternum, right? Sternum, ribs, hips, and tibia, right? These are the most associated with leukemia, right? The bone pain. So sternum and ribs, will they come? Will the patient come and tell you, doctor, my sternum is hurting? Huh? Right? Never. They will come and tell, this chest area is hurting, right? Painful. All right. Okay. So these are some of the things that are going on, right? Now, guys. So these are some of the things that you see. Apart from this, what happens, guys? Now, what is happening inside the bone marrow, inside the compact space? Lots and lots and lots of cells, right? Eventually, these guys start making their way into the blood. Eventually, they start making their leaking into the blood. These large numbers of cells eventually start leaking into the blood, right? These are what? Are these normal cells? No, these are not very well functioning cells. So we call them leukemic cells. Leukemic cells. They start leaking into the blood, right? They are not well differentiated. Some of them blasts and the others somewhere in the middle, right? So these ones, guys, now these are what? These are, when we say leukemia, leuco, these are white blood cells. We are talking about white blood cells. So these white blood cells, guys, are not very well functioning. WBC, WBCs, their functionality is lower, as we discussed, right? Because of this, look at this, guys. One thing, when these leukemic cells now start coming into the blood, right? Several things can happen. One thing is, guys, what we call leukostasis. Why does this happen? Due to the overcrowding within the vasculature, guys, right? In the severe cases, even the blood vessels don't have enough space to hold all of these cells, right? So there is going to be a large number of cells coming into the blood, giving rise to what we call leukostasis. Leukostasis. Basically, guys, due to the large accumulation of these white blood cells, the blood flow rates reduce, the viscosity of the blood increases, right? This is going to give rise to some manifestations, which we will talk about when we come to those specific cases, right? Leukostasis, right? Then, apart from this, when there is a large number coming into the blood, from the blood, they can go to surrounding tissue. This is what we call tissue infiltration. Tissue infiltration, right? Tissue infiltration, guys. Okay. Basically, this is metastasis, but we do not use the word metastasis, guys, unless there is another cancer originating. Firstly, it will cause infiltration. It will go to a site, and if it starts hyperproliferating there, right, causing genetic changes there, that is when we will call it a metastasis. So first, here it's a tissue infiltration, right? So here we can have, they can go to the liver, hepato, or the spleen, right? Hepatosplenomegaly, right? Hepatosplenomegaly, right? Okay, and then they can go to the lymph nodes, guys. That will cause lymphadenopathy, right? Lymphadenopathy. These are the two that are common for all the forms of the leukemias, right? Okay. Later, we will see some specific ones when we come to the specific types. Some can go to the CNS, some can go to the testes in males, right? We'll talk about those when we come to the specific types, right? These are the general ones we're talking about, right? Now, here's what I want you all to know, guys. So these are the general things that happen in the leukemia. Apart from these, guys, just put a star somewhere. And apart from all of these happening, right? Leukemic cells, they have ability, they have mechanisms to increase their lifespan, guys, right? Increase the lifespan of these dysfunctional cells, right? By escaping apoptosis. Now we know, guys, our immune system, the moment it notices a dysfunctioning cell or a not properly functioning cell, what will it try to do? It will try to get rid of it as soon as possible, right? But the special case in these leukemic cells is that they have different mechanisms. right? We are not going to go to those because most of them we don't even understand, right? And whatever we know, they are highly complex, right? We don't need to talk about them. Genetic mechanisms, guys, they cause mutations, and they have various mechanisms to increase their lifespan and escape apoptosis, right? Just keep this written down there. We will see how this plays a role when we come to the specific types. Right. So this is the basic mechanism, guys. So now we started off with imagining that this something happened in the bone marrow that caused the leukemia. So what caused this? What caused this? How? How? This is the question, right? Any answers? Anyone knows anything? Basically, guys, we are going to go into the etiology now. What is going on? What is causing this? What do you all think? Huh? Come on, hypothesize something, huh? Anything? This is a cancer, no, guys? What do you all usually know about etiologies of cancers? Anything you all know about? Forget leukemia for a second. Any type of cancer?
Can be hereditary.
Hereditary component. There can be some hereditary component. Carcinogens, excellent. There can be some agents that are going to induce some mutations or some genetic defects that are going to give rise. Excellent. So you all are all correct. Okay, so you all are good. Look at this, guys. Etiology unknown. Write this down. Very important, right? Etiology unknown, but we do know some associated agents, some risk factors, right? What is this? Look at this, guys. We'll make it like a process. What is going to happen is, guys, firstly, there is going to be exposure to some causative agents. We'll talk about what they are. Causative agents, right? Exposure to some causative agents. Then, after some time is when the patient starts manifesting leukemia, right? This period of time in between, guys, we call it the lag time. The lag time for the development of leukemia, right? Now, this one, for acute, what did we say? For acute leukemias, it can be days to weeks, right? Chronic, most of the time, guys, it takes years, sometimes 5, 10, right? Sometimes 15 years, okay? Right? Now, the most hard evidence you can find of this, right? The Hiroshima bombing, guys, you all know, right? So when there was this bombing, right, there were several cases of at that time they didn't even know that these were leukemias, right? They didn't know what was going on, right? These people started manifesting thrombocytopenia, bleeding uncontrollably. I will send you all some videos when I'm free, right? It's there all over YouTube, right? Actual documentaries. Some cases, guys, up to about 10 years, nothing happened to those people. They were nicely living their life. Suddenly they started developing leukemias, right? So those are the chronic forms, right? After the bombing, after 10, 15 years, they developed leukemias, right? Okay. So that's the lag time. Now, look at this, guys. What are these positive agents that we have identified up to now, right? First, one of the first things are ionizing radiation, right? Okay. Now, any aspiring radiologists? I'm not good. I'm not saying you all will get leukemia, but you all will like, let's say you become a radiologist someday. They will give you this device to hang around your neck. So whenever you're working in the lab, whenever you're working in the hospital, in the radiology department, whatever, you will be wearing that, right? And throughout your career, right, they will monitor, right? And once you reach the maximum radiation level, you will have to stop work, right? You will have to stop work because beyond that, it's harmful. Yeah. Yeah. So ionizing radiation. What is this ionizing radiation, guys? Another thing. In children, let's say we have, okay, now I'm telling you all, okay, we have a child with acute lymphocytic leukemia, right? Let's say he's 2.5 years old, or let's say he's 2 years old. And I'm telling you all, we have done the necessary examinations, we have done the findings, we found out that it is ionizing radiation that caused this. How? He's 2.5 years old, he's 2 years old. How? Why? Let's say he was not in a bomb destruction site, and let's leave those weird explanations aside. Anything else you all can think of?
Pregnancy.
In the womb.
The mother. Pregnancy.
The mother, right? Now I am adding a history, right? The mother had a severe motor traffic accident, right? During, let's say about during the first week of her pregnancy, right? Okay. And they had to do a lot of x-rays to find out which of her bones were broken. That is probably the cause there. So x-ray scans during these are, guys, we do ultrasounds, right, for this safety, right? So x-ray scans during the pregnancy, right? Now here, guys, it is a benefit analysis, right? We check how, let's say the mother underwent a road traffic accident, right? You cannot say just because she's pregnant we can't do x-rays. No, right? Depending on the severity, if there is a more benefit to the mother, we will have to do that at that moment, right? But we try to minimize, we'll take all the precautions, right? But there are instances where we have to do x-rays, right, where we cannot let that go. So that is one example. The other thing is, so just note down, pregnancy radiation, right? X-rays during pregnancy. The other thing is, guys, radiotherapy for ankylosing spondylitis, ankylosing and Kispon. You all study this in rheumatology, no? Right? So there are some radiotherapy. So these ones, guys, ankylosing spondylitis, you all know it is a problem in the vertebral column, right? So when you give radiotherapy there can be ionizing radiation inducing the leukemias. However, these are rare, guys. These are not common, but possible. Okay. Then another one, chemotherapeutic agents given for cancers itself. Now you see the issue. Let's say a patient has a cancer. You give them certain one known one is, guys, you all have already heard this. Tell me, melphalan, do you all remember? Where did we give melphalan? Multiple myeloma. One of the drugs known is this melphalan, right? It has a risk, right, to give rise to leukemia, right? Apart from these other alkylating agents, certain cytotoxic drugs are there, right? We don't need to know these. And then industrial, guys, the most common one, benzene, exposure to benzene, right? This one, guys, we don't need to know the mechanism, but basically this one, direct cell injury to the bone marrow, right? There is a damage on the molecular level, molecular damage, right? Okay. These are some of the things we know. Apart from this, look at this, guys. Now, somewhere here, draw an arrow joining into this. Apart from these positive agents exposure, there are certain pre-existing conditions, guys. Pre-existing conditions that the patient already has that is associated with giving rise to leukemia. What are these, guys? Here's the important thing. One is Hodgkin's lymphoma. Hodgkin's lymphoma. Now that will be your next topic. Shan will be teaching you all the lymphoma part, right? Hodgkin lymphomas can give rise to leukemias. Another one is, guys, multiple myeloma. We have already talked about this. Multiple myeloma can give rise to leukemias. There is an association. Mechanisms are not very clear, right? But there is an association, right? Then you all can put another arrow, right, coming down. We have some other things, genetic problems, genetic defects, right, that the patient might have that can give rise to the leukemia. Here, guys, we are going to talk about certain chromosomal translocations, right? Specifically, we are going to talk about something called the Philadelphia chromosome, right? We'll talk about that. Apart from this, guys, trisomies, right? Monosomies, right? Specifically trisomy 21, right? Down syndrome. We're going to talk a little bit about Down syndrome. There is an association with leukemia, right? These kind of genetic defects also can play a role, right? Okay. So this is the pathophysiology, right? This is how deep we are going to go, right? I know it's not much, right? But this is more than enough, okay? More than enough. So if you look at books like Kumar and Clark's, Davidson's, they will not go further than this, guys. If you look at Harrison's goes a little bit more further, actually a lot more further, but that is completely unnecessary, okay? It's difficult, guys, to understand those concepts, okay? So we'll take what is only necessary for MBBS. Right. Is everyone clear up to this point? All good? This is your introduction, right? Give me a thumbs up. Let me see your faces. All good. Right. Excellent. Excellent. Now we will go to the specific types, right? So we will start off with the acute leukemias, guys. Acute leukemias, right? And the first one, right? Okay, first put the big topic, acute leukemias. Acute leukemias. Right? And the first one we are going to talk about, right? Acute ALL. Can someone tell me the abbreviation? What is this? ALL is?
Acute lymphoblastic.
Acute lymphoblastic leukemia. Acute lymphoblastic leukemia, right? Okay. Right. Right. Look at this, guys. This one, what I want you all to know, the first point, this is the most common pediatric cancer. Now, look, notice these words, guys. This is not the most common pediatric leukemia. This is the most common pediatric cancer, right? In children, this is the most common cancer. Okay, not the most, it is obviously the most common leukemia in children, but it is also the most common cancer, right? Okay, so basically this is what we said, newborn to 14 years of age, 13 or 14, early teenage years, right? Now, this can also occur in adults, guys. Obviously, adults also can have it, not as common. But one thing I want you all to know, in adults, ALL is of poor prognosis, right? It's of poor prognosis, right? In children, much better prognosis. It is a very common cancer in children, the most common one, and much better prognosis. In adults, however, not very common, but poor prognosis, right? Now, tell me this, guys. Now I'm one of your juniors. I'm a first year student. I'm coming and asking, Ayya akka, okay. What does the word ALL mean? In one sentence, can you all just tell me? What is it? The word ALL, acute lymphoblastic leukemia. What is it? What is it? How can you all tell me?
Cancer of the lymphoid cells in the acute stage. I don't know.
Okay, so we have gone from a one sentence to a paragraph now. Huh? Okay, look at this. Okay. Listen to this, guy. Write this down. ALL. This is a malignancy of B or T lymphoblast. Correct? A malignancy of either, because lymphoid, we know there are only two types, right? The B or the T. So this is a malignancy of B or T lymphoblasts, right? Lymphoblasts. Okay, write that down. Huh? Right. Okay. Look at this guy. We'll talk about some clinical. We'll come to the we are going deep into this. We'll first do the easy stuff. If we look at the clinical manifestations, guys, now what if we say acute ones, right? They develop rapidly, right? They can have these bone pains, guys. Bone pains. They will complain of the bone pains significantly, right? Apart from this, right, they can have hepatosplenomegaly, right? Lymphadenopathy due to the infiltration, which we talked about in the basic mechanisms, right? And then, guys, look at this. They can also have some constitutional symptoms, fever, fatigue, these kinds of things. Okay, fever, fatigue, these kinds of things, right? Now, they will, what do you think of their development of bone marrow suppression? What do you think? Or bone marrow failure? Will it develop rapidly or will it take time?
Rapidly.
Rapid bone marrow failure, guys. So these patients, they start manifesting the anemia, the neutropenia, the thrombocytopenia, these things, they start manifesting them rapidly, right? They start manifesting them rapidly. Okay, rapid bone marrow failure. Now, look at this, guys. Come here a little bit. Let me take this diagram. All right, if we come back to, I'm taking this diagram again and again. You all don't need to draw it over and over again. Nah? I'm taking it just to reinforce this in your heads, right? Now, if we take this diagram, right, where is our issue? Somewhere here, somewhere here. This is where our issue is, either the B or the T lymphoblast, right? So based on this, guys, we can have what we call a B cell ALL or a T cell ALL. T cell ALL. Okay, a B cell ALL or T cell ALL. Out of these two, guys, the B cell is the most common. 70 to 80% of the cases we have this B cell ALL. Okay, T cell is much more rare. T cell ALL is much more rare. Right? Right. Look at this, guys. So if we look at the lab studies, when we look at the lab studies, lab studies, right? One thing is, guys, we can look at the peripheral blood smears. Peripheral blood. When we look at the peripheral blood, we will see, depending on the stage of the disease, guys, WBC counts will be abnormal. Now, look at this. Pay attention to this. We are not saying WBCs are high. We are not saying WBCs are low. We are saying abnormal. Abnormal. Why? It can vary based on the stage of the disease. At some stages, it can be high, right? As the disease progresses, as the bone marrow fails, it can be a little bit low, right? Sometimes, guys, it can be normal as well. We don't know, right? We don't know, right? So these WBC counts are abnormal. They are not very diagnostic, not very diagnostic. In the late disease, however, you all know, in the late disease, right, what happens? We have bone marrow failure, bone marrow failure. So the healthy WBC counts will start dropping, right? Now, if you look at the WBC specs, right, they will be what we call lymphoblasts. Lymphoblasts. Okay, lymphoblasts. Now, here is the important thing, guys. Let's check if I have put a picture for you all of the lymphoblasts. This is not a very good picture. Okay, it's okay. I haven't put the two differentiating. Look at this, guys. What I want you all to know, lymphoblasts structurally under microscope, they look quite similar to myeloblasts, right? These are similar to myeloblasts, right? Myeloblasts. So how do we recognize now? We take the blood sample, right? We see some abnormal cells which are blastic in nature in the blood, in the peripheral blood, but we can't differentiate if it is lymphoblast or myeloblast just by looking at them, right? So how do we identify, right? And the second thing, we don't know, it is difficult to identify if they are B cell blasts or T blasts, B blasts or T blasts. That is also difficult to identify, right? So how do we do this? We do this based on surface markers, guys. Surface markers, right? Look at this, guys. I have put a picture for you. This, right? Here, on stem cell maturation, guys. On stem cell maturation, right? First thing, we have this marker called TDT, right? TDT. This is this one, guys. This, if you all want to write down, TDT stands for terminal deoxytransferase, right? This is nothing special. We just use it as a marker. It's actually an enzyme. It is an enzyme found in these cells, right? TDT, right? TDT, it is a DNA polymerase enzyme that is found only in the nuclei of lymphoblasts, not in myeloblasts, right? This is the first point I want you all to know. TDT only in lymphoblasts. Write this down, huh? Only in lymphoblasts, right? Myeloblasts do not have this, right? So now using this marker, we can test for this marker. Using this marker, what can we differentiate in the blood smear? Huh?
If it's a myeloblastic.
Yeah, we can differentiate if this is a myeloid problem or a lymphoid problem, right? Because the lymphoid ones will have the TDT positive, right? Okay, the lymphoblasts. Then the next thing, guys, to differentiate if it is B cell ALL or T cell ALL, there we have these CD markers coming into play, right? CD markers, right? What are these CD markers, guys? These ones are cell surface markers. So, for example, if you look at the B cell, this lineage, the top one, the green ones are the B cell lineages, guys. Here we initially have something called CD10, right? And on maturation, CD10 disappears and gives, we have some other markers, CD19, 20, 21, things like this, right? If you look at the T cell, right? Eventually, in the early stages, we have CD7, CD3, CD5, these kinds of one, eventually 8, right? Look at this, guys. How do I'll give you all a rule of thumb. This is not always the case. Remember this, write this down in red. Not 100% of the time, but 98% of the time, and almost always in your questions, right? In your questions, write this rule of thumb, right? Okay. CD1 to 8. CD1 to 8. If you see these, they're talking about T cells. They're talking about T cells, right? And CD10 to 23 or higher, basically these are B cell, basically higher than 10, guys. 10 and upwards, we are talking about the markers are B cell markers, right? B cell markers, right? 1 to 8, these are T cells. 1 to 8, these are T cells, T cell markers, right? Now we will see some specific conditions. Now, sometimes we will see, I will tell you all when we come to that part. Sometimes we see CD5 on the B cell. That is an issue. We'll talk about that later, right? We'll keep that later. But for the general condition, this is the case. So now what? Now we know, first thing, we can use the TDT marker to find out the lymphoblasts. And out of the lymphoblasts, to know if they are B or T, we can use the CD markers. Everyone clear with this? Right? All good? Right. Okay. So this is what we look for in the peripheral blood, right? We can isolate the type of cell. The second thing, guys, we can do a bone marrow aspirate. When we do the bone marrow aspirate, what type of cells? Will it be the blasts that are high or the sites that are high? When we talk about ALL. Blasts. It is acute lymphoblastic leukemia, right? So the blasts are high. So here, guys, we have blast infiltration greater than 20% of the bone marrow is occupied by blasts. Okay, blasts greater than 20%. This is one of the diagnostic criteria, right? Okay, blasts are greater than 20%, right? Okay, right. Now let's look we'll dive a little bit more deeper, guys. We'll go into the specific subtypes. The first one, the most common one, is what we said, B cell ALL. This is, we said 70 to 80% of the cases are this, B cell ALL, right? Right? This one, guys, Again, right? Even these subtypes, we don't know the exact cause, but we know some relationships. Look at this. Usually, when you're doing the diagnostics, guys, you will see their CD marker is most of the time CD10 positive, CD10, right? CD10, most of the cases, right? Usually CD10, obviously they can have any of the other B cell markers, right? What are B cell markers? The higher numbers above 10, right? 20, 23, 19, all of these are B cell markers. They can have all of that. Most of the times you will see this CD10 positive, right? Almost all of the time, right? Then guys, there are some associated genetic defects, right? Associated genetic defects specifically with this B cell ALL. Look at this. First, write them down. One of them, the first one, right? Trisomy 21. What is this? What is trisomy 21?
Yeah.
Down syndrome. Down syndrome, right? Down syndrome. Second one is, guys, second one, translocation between, it's a reciprocal translocation between chromosome 9 and 22. 9 and 22, right? Now this one, guys, but now just write it down as Philadelphia chromosome. It's going to give rise to something called the Philadelphia chromosome, right? This one is the, we will talk to a great depth, right? When we go further down, not for ALL. For ALL, there can be, this Philadelphia chromosome can be there, right? But not always. So we will just mention it here, the name. Later we will discuss what is actually happening, right? So Philadelphia chromosome. Another, the third one is, guys, another translocation, 1221, right? This one we'll talk about here, right? Look at this. What are these and how are they causing B cell ALL? For the major part, we do not know, right? But there are some things that we know. Look at this. Trisomy 21. Trisomy 21. What does this mean, guys? There are, if you look at the chromosome number 21, there are 3 copies now. This is what we call a trisomy. 3 copies, right? 3 copies. Here, guys, in chromosome number 21, there is an important gene here. Now, this is, we are going away from MBBS, but just for us to know something, right? Just for us to know something. There is an important gene here, right? This is called, guys, the GATA, right? GATA1 gene, right? This is a transcription factor, right? What it does is, guys, it binds to and controls other genes in the same chromosomes and controls hematopoietic proliferation. That means within these chromosomes, guys, there are other genes. We are not going to talk about them. There are other genes that are responsible for hematopoiesis, right? What GATA1 does is, guys, GATA1, it binds with them. Whenever necessary, they will activate those hematopoietic genes. Whenever unnecessary, they will stop them. They will stop them from functioning, right? So this is what GATA1 does, right? Those hematopoietic related genes, guys, we don't need to know. There are multiple rungs, one, right? We don't need to even talk about. If anyone's interested, drop me a message. I will drop some articles. If you all want, if you all have no exams coming up, you all want to get confused, drop me a message. Okay, I will send some articles. Very complex, right? But I mean, if you all want to read, just drop me a message. So this GATA1 gene is basically a regulator of hematopoiesis. It's a regulator of hematopoiesis. Now, what can happen, guys? GATA1 gene can undergo mutations. Right? What is the concept I want you all to understand here? When there is an extra chromosome, we have an extra GATA1. When there is an extra GATA1, what is the chance of us getting another mutation? A third mutation is higher, right? So the more chromosomes we have, the more problems we can have. Understood? So here, guys, in trisomy 21, what happens? There can be some mutations, right? And since there are 3 copies now, right, the mutations can phenotypically show up much more severe, right? So this, what happens is, that. So this is why it is associated with ALL, trisomy 21, right? What they say is, guys, for your MBBS, this is what I want you to know. It can be associated with Down syndrome, and there is a 10 to 20 times higher chance of a Down syndrome child developing ALL as opposed to a normal child. Okay, right? Right. Then this Philadelphia chromosome, guys. This Philadelphia chromosome, this is mostly in CML, guys. Right? This is about 95% seen in CML. But in ALL, a few minority of patients, guys, about 15 to 20% of patients can show this, right? Can show this Philadelphia chromosome. Now, later I will talk about when we come to CML, I will tell you what this chromosome does, how it is working. We'll talk about all of that. Don't worry, right? For now, just keep it Philadelphia chromosome. For this ALL, what I want you all to know, right? This is associated with poor prognosis. Poor prognosis, right? This Philadelphia chromosome or the translocation 922 is associated with poor prognosis. And you all can put a second point. It is seen almost always in only in adults, guys. Children with ALL usually don't show this translocation. They don't have this translocation. On the other hand, children with ALL have this translocation, guys. This is seen in children with ALL. And what's the important thing? This translocation in children, if you see it, it is an indicator of good prognosis in that child who is suffering from ALL, right? Now, why this is? We don't know, guys. Okay, why these translocations? One of the easy explanations we can give why this T2112 is good prognosis is, if you look at the textbooks, they say they are more responsive to therapy, right? We do not know why they are more responsive to therapy, right? Those are questions we do not know answers for yet. This, okay, now I told you 922 is Philadelphia chromosome, guys. This one, does anyone know 922? I will discuss it in CML. Does anyone know the fusion gene formed there for Philadelphia chromosome? For Philadelphia chromosome? Have you all heard something like this? BCR-ABL gene. This Philadelphia chromosome is that, guys. I will tell you all how that formed. Don't worry. Right? There is something called the BCR-ABL gene. Here, for this translocation 1221, we have a gene called the TEL-AML1. Don't get confused, not MBBS. This is why I said, right? Majority of these not necessary. But what I will tell you all this. This TEL-AML1, I don't even want you all to know the name. Just remember, from this 1221 translocation, the resulting gene, I don't want you all to remember TEL-AML1. The resulting gene, this one inhibits differentiation of blasts, thereby giving rise to leukemia. Okay, this is how this translocation gives rise to leukemia. So why it is good prognosis, we don't know, guys. They say it's more responsive to therapy. Okay, but you have to know, guys, this good prognosis, poor prognosis story for your MCQs, especially your true or false, right? And your single best answers, right? Okay, right, don't worry. In the end, I will give you all 4 summary cards. They will have the absolute essentials you all need for your exams. Right, that is B cell ALL. Leave that aside. We'll go to T cell ALL. T cell ALL. T cell ALL. Now just look at this, guys. Before we go to T cell ALL, B cell ALL. What do you all think? Will adults be able to survive it more, or children be able to survive it more? Basically, if I ask adults versus children, who has the better prognosis in B cell ALL?
Children.
Children, right? How can you all remember that, guys? Just remember the translocation. So you all know adults have the Philadelphia chromosome, right? So poor prognosis. Okay. The problem is, guys, I want you all to remember Philadelphia and poor prognosis, right? It has come many times in questions. You all have to know that, right? For ALL, Philadelphia chromosome is poor prognosis for ALL. Okay. Wait a CML, you will see it is good prognosis. See, this is the issue with this. Don't worry, right? We'll go step by step. Right. Come to T cell ALL. T cell ALL, what did we say? This is more rare, right? 80% of the time it's B cell. This one is rare. Less common. Here, guys, usually the CD marker, right, usually is CD7, CD7 positive, CD7 positive, right, the cells. Okay, here, guys, most common age group is teenage years, right, somewhere between 13 to 19 sort of, right, okay, and adolescents basically, and males greater than females. Adolescents and males greater than females. Not very necessary for you all to remember these. Here's the important thing I want you all to remember. Normally, guys, now forget the ALL for a second. Normally, you all know once T cells are released from the bone marrow, right? Unlike other cell lineages, they go to some other places to further mature, right? If you all remember, one of those places is what? Thymus, right? If you all remember, T cells go to the thymus to further differentiate, right? That is normally. So in the same way, guys, these in the ALL also, these T cells, they can go, one is they can go to lymph nodes, obviously, and the other thing is they can go to the thymus, right? These neoplastic T cells, they can go to the lymph nodes and the thymus. In the lymph nodes, obviously, they will cause lymphadenopathy, right? Lymphadenopathy, right? That one is not very specific. A lot of leukemias can show lymphadenopathy, but the thymus involvement is seen here. Thymus, guys, what happens in T cell ALL? We have what we call a thymic mass, right? The thymus can get enlarged, right? This is a classical sign of this T cell ALL. It's rare, but if it's there, we can most likely see this thymic mass. So here, how do you diagnose this? One thing on X-ray, what will you see? You will see like a mediastinal widening, right? Mediastinal mass on X-ray, right? Mediastinal mass somewhere here in the chest, you will see a big whitish opacity, right? And often it will be accompanied with pleural effusion and all of that, but not necessary for your level, right? Here, guys, if it is too large, if the thymic mass is too large, it will start giving rise to some certain clinical manifestation. What do you all think? What are the possible manifestations if the thymus starts enlarging? Any idea?
Dysphagia.
Excellent. One is dysphagia, compressing the esophagus. Another one?
Dyspnea.
Dyspnea, shortness of breath, right? Tracheal. We don't actually call it shortness of breath because there is no problem with the lung. But what can happen is we say tracheal obstruction. There will be some dyspnea, difficulty in breathing, right? So one is dysphagia, and then tracheal obstruction giving rise to shortness of breath, right? Or dyspnea. Another one. Anything else? Anything else in this area that can get compressed?
Hoarseness of voice.
Hoarseness of voice. Not really, guys. It doesn't come all the way to the larynx. Not that high. Not that high up. Something else here? Something related to the heart? Anything? No?
SVC.
Excellent. Superior vena cava syndrome. Guys, write it down. Superior vena cava like syndrome. Right? Like syndrome. Right? This is what we call it. Right? Due to the thymic mass, we call it a SVC. It's a like syndrome. Superior vena cava like syndrome. Similar manifestations. Just like the SVC. Right? Superior vena cava like syndrome. Right? Okay, we have studied SVC, right? We studied in cardiology, and again in lung cancers also we talked about superior vena cava syndrome. Okay, right. So those are the main things I want you all to know about this T cell ALL, right? Okay, now we'll come to the management of ALL, MX of ALL. These ALL in general, now again, we are not going to divide them into B cell, T cell, no. Now we are just again talking about acute lymphoblastic leukemia, how to manage it, The first thing, these are MCQ points. The first thing I want you all to know, guys, prognosis better in children, right? You all now know why, or at least we have hypothesized why, right? Okay. Better in children. In children, guys, greater than 80% can achieve what we call remission, right? They can achieve remission means, guys, the disease manifestations they disappear and the patient is stable, right? That is what we call remission. So how do we treat this? First of all, some supportive therapies, guys. Supportive therapies, right? These are basically, guys, you are trying to treat the other manifestations, right? For example, if there is severe anemia, we can go with blood transfusions, right? Okay. If there is neutropenia, we have to give them infection prophylaxis, right? So antibiotics and antifungals, usually broad spectrum antibiotics and some antifungals, right? And just remember, guys, platelet count, we want to, now with the progression of the disease, guys, platelet count can drop, right? Platelet count can drop due to thrombocytopenia. Platelet count, we want to keep it subnormal levels. Usually we say, guys, specifically, we can say greater than 50,000, right? 20 to 50 is also okay, right? Some books say 20 to 50. You always see some books say 20 to 50. What is the normal platelet count, guys? 150 to 450, right? 150 to 450. So for these cases, 20 to 50 also they say is okay, we can manage, right? Manage worst case scenario, we can do some interventions and manage. But if it goes less than 20, becomes difficult, right? For the most case, try to keep it greater than 50. How do we try to keep it greater than 50? If they are dropping, what can we do? Platelet transfusions. Go and donate platelets, right? Platelet transfusions, right? Then now we'll come to the actual treatments, the actual treatment protocol, guys, right? We have 3 stages. The first one is what we call remission induction. We want to induce the remission. Remission induction, guys. We most of the time we use prednisolone. No doses, no, even these treatments, guys, right? They will very, very rarely question you, right? Very rare. Okay, but just know remission induction is usually prednisolone, right? Then we have what we call remission. Now, after we induce the remission, we have to fully seal it, guys. We induce the patient to come into a state of okay, no manifestations, right, or reduced manifestations. Then we fully seal it. We consolidate it. We call it remission consolidation, right? How do we do remission consolidation? There are several drugs, guys, right? Look at this. One of them is called vincristine, right? Write this down. I will tell you all how they work. Second one is methotrexate. You all already know this one, right? Very common. And the third one I want you all to know is cytarabine. Vincristine, methotrexate, cytarabine, right? These are the options we have, right? Sometimes, depending on the severity, they can combine 2 of these drugs or all 3, right? Depends on the severity, right? MBBS, you all don't need to know how to give this, right? What do they do, guys? What is this vincristine? Guys? This guy is a spindle inhibitor. You all know that during mitotic cell division, we have the spindle formations, right? This guy is a spindle spindle fiber inhibitor, right? Right? It basically goes and binds to spindle fibers and crystallizes them, guys. The mechanism is very beautiful, not necessary for our levels, right? And therefore arrests the cell from mitotically dividing. Mitotic division gone. Methotrexate. How does MTX work? Anyone knows? This is a common one. No? You all must have heard. How does this work? The basic mechanism.
Folic
What
acid
Sorry?
inhibition of folic acid.
Yeah. Okay. Correct. Dihydrofolate reductase inhibition. Correct. Yes. Yeah, that's a little bit deep, Tarinder, but good. Yes. That's the actual mechanism. But basically, DNA synthesis inhibitor, right? DNA synthesis inhibitor, right? Good. It inhibits something called dihydrofolate reductase. Right. Next one, cytarabine. Cytarabine, guys, how does it work? This one, it's a DNA replication inhibitor. It basically stops the cell cycle at the S phase, guys. It stops the cell cycle at the S phase, right? Okay. So these ones, now first we induce the remission using prednisolone, then these guys help to seal the deal, remission consolidation, right? Okay. Then once the remission is now consolidated, right, done and dusted, we have what we call remission maintenance. You can't abruptly stop. For ALL, we have something called remission maintenance, right? Maintenance, remission maintenance. Here, guys, again, there is a place for methotrexate, right? Not, you all know, same mechanism. The second one is something called 6-mercaptopurine, MTP, mercaptopurine, 6-MTP, same thing, 6-mercaptopurine. Just from the name, what do you think this does? I know it's difficult to say from the name, but you can use some words in the name.
Urine inhibition.
Excellent, right? Exactly that's the extent of what I want you all to know. Don't need to know anything more than that, right? Purine synthesis inhibitor, right? Purine synthesis inhibitor, right? So when purines are not there, guys, you all know DNA synthesis drops, RNA synthesis drops, protein synthesis, everything drops when purines are not there, right? So basically, this is an anti-proliferative agent and it helps with apoptosis. It promotes apoptosis. It promotes apoptosis. Okay. Right. Now, put this as a star, guys. Just note, we said acute lymphoblastic leukemia. In children, it's good prognosis, right? Especially because they have the translocation 1221. Whereas in adults, this is a bit more complicated. Prognosis is a bit more poorer, especially because they have the Philadelphia chromosome. What I want you all to know is, guys, for ALL, relapses are common. So let's say you did the induction, you did the consolidation, you did the maintenance, patient didn't show any symptoms. So after about a year or two, you stop the medication, right? After the remission maintenance is done. But say about another year or two, they relapse, they get the disease again, right? So this relapse is much more common than the other forms of leukemias for ALL, right? Relapse is common. So what we do is, guys, once the patient has gone into full remission, once they are fully in remission, right, then we can make, based on this is not your decision as the newly appointed doctor. These are specialist decisions, consultant level decisions. They will make the decision based on the patient's age, risk factors, family history, based on all of that, and even their financial status, right? They can propose or consider allogenic stem cell transplants, right? Can be considered once full remission is achieved, right? Especially, guys, if it's relapsing is one cause. The other thing, if it is an adult and the Philadelphia chromosome is positive, if it is an adult and the Philadelphia chromosome is positive also, we can consider an allogenic stem cell transplant. Okay. Right. Now, look at this, guys. So now we have talked about how to get the remission. What if this patient has the Philadelphia chromosome positive? You can put a note. We'll talk about some important points. Note the first point, guys. If the patient is Philadelphia chromosome positive, right? There is a drug called imatinib. I will teach this drug because we have to first talk about CML and we have to talk about depth in the Philadelphia chromosome, and then we can understand imatinib, guys. For now, just keep it written down, right? When we come to CML, I will teach you, right? So imatinib can be given if the patient is pH positive in any of the stages, guys. During induction, during consolidation, during maintenance, doesn't matter. Any stage you can give imatinib, right? I will teach you all that drug. Don't worry. The next special point, guys, about ALL is that in ALL, these lymphoblastic cells, they have what we call sanctuary sites. That means what? They migrate to certain other tissues. This is specific for this ALL, right? They like to migrate to some specific tissues. And in those tissues, guys, there is poor penetration by chemotherapy, right? Therefore, it's difficult to control those when they go to those sites. What are those sites, guys? The most commonly known one is testes, right? The testicles, right? In males, right? Testes, yes, no? Yeah, testes. The second one is CNS. This can be both male or female, right? Now, because of this, guys, we have to do further testing, specifically if this is a young boy with ALL. And what do you think about maintenance therapy, guys? Maintenance therapy, guys, for boys is much longer than for girls due to this specific reason, right? So for boys, we give about 3 years, of maintenance therapy, whereas girls, 2 to 2.5 years of maintenance therapy is enough. Okay. These are things that are coming in your questions. So now, traditionally, if we are going like super deep, like some other chapters that we did, what is the question that you will have? Why these sanctuary sites? Why these fellows like going there? Why are they attracted? No one knows. Right? Or at least we are still trying to find out why. Right? Okay. And just note here, guys, CNS, if it goes to the CNS, regardless of child or adult, prognosis is poor, right? If it infiltrates the CNS, right? Right? Then put another note. Good prognostic indicators of acute lymphoblastic leukemia, good prognosis in ALL. These are what you need to know, guys, for your exams. One thing, younger the patient, the better. Right? Specifically, if they're in the 1 to 13-year age group, their prognosis is very, very good, right? 80-85% can achieve remission, right? Okay. Then Philadelphia chromosome negative ALL. This is also good prognosis. When the Philadelphia chromosome is negative, that's good prognosis. Right? Then another one, guys, WBC counts. Now we said what? In ALL, it can be abnormal. Sometimes it can be very high, sometimes it can be very low, right? WBC counts, guys. What is the normal range? 4,000 to around 11,000. Some, 4 to 10, 4 to 11, right? Depends on the lab that you are going with. Usually 4 to 10. Usually, guys, if we can keep it between the normal range to under 50,000, from the normal range under 50,000, that is good prognosis, right? If it goes above 50,000 or goes below the normal range, problem, right? So as long as it is in the normal range and under 50,000, it's a good prognosis. Good. right? Then guys, the last one I want you to know, overall, B cell ALL has a better prognosis than the T variant. Okay, overall, right? Okay. Everyone clear? Everyone clear? This is it for ALL. This is it for ALL. Now ALL is the little bit of a larger one, guys. Other ones are not this large, right? We'll do AML also, and then we'll take a small break, right? We'll go to the second. Guys, all good up to this point? ALL is done. Huh? Give me a thumbs up, right? All good, right? I know you all will have a lot of questions after today's class, a lot of blanks to fill. If you all have questions, drop me a message. Huh? Whatever we know, right? We'll try to discuss. Rest, we'll leave them aside. Okay. Right. Second one, AML, acute myelogenous leukemia. Acute myelogenous leukemia. Just by hearing the words acute myelogenous leukemia in the peripheral blood smear, what can you tell me now? What sort of cells will you see?
Myeloblast.
Okay, they are in the myeloid lineage. Okay, anything else? A bit more. Now you all can be a bit more specific based on some markers that we have talked about. Huh? Think. Look back. Go 2-3 pages up. Anyone? Try.
TDT will be low.
Ah, excellent. TDT negative. This is the first thing I want you all to now understand. TDT negative. Why? Those are only in the lymphoblasts. They are not in the myeloid. Right? So acute myelogenous leukemia. Right? TDT negative. Right? Don't forget these. Right? Okay. So again, let's take a few introductory points. This is a malignancy of myeloblasts. Acute, what did we say? At the very top, at the blast level, right? So myeloblasts, right? Here, guys, the age range is about 40 to 60, right? 40 to 60, this is what you will get in your questions. And again, males greater than females. That's not necessary for you all to know, but just for completion. Males greater than females. Here, guys, the major manifestations here, right, is due to the bone marrow failure. Again, right, bone marrow failure. Due to myeloblasts accumulating in the bone marrow and then taking up space, taking up resources, therefore bone marrow failure. Here, also just note, guys, also, although this is a disease of the elderly, right, 40 to 60 years of age, this one also has an association with trisomy 21. Trisomy 21. Not as prominent as ALL, but there is a possibility, guys. With trisomy 21, there is a documented association, right? Higher risk to develop AML, right? Right. Look at this. We'll look at the diagnostics a little. The labs. In the lab studies, guys, first thing, if you look at the peripheral blood, you will see a lot of blasts that have now come, myeloblasts that have come into the blood. These are myeloblasts. You all know one thing already. This is TDT negative. Right? TDT negative. Another test, guys, for these myeloid cells. You all know inside the myeloid cells, guys, they have this thing called myeloperoxidase. This is an enzyme. This is an enzyme found inside, mainly in myeloperoxidase is seen in mainly in what type of WBC? Huh? I taught you all this in SLE. Huh?
Yes.
Huh? Sorry, this was not in SLE, guys. This was not in SLE. They are not in SLE. I taught this to you all in endocrine, in some endocrine related chapters. Remember, we did something. We do some tests for certain diseases, even in some respiratory conditions. Something called P and K, C and K. You all remember? Yeah. What?
Vascular.
Neutrophils.
Anti-neutrophilic cytoplasmic antibody. I don't know if you all remember those, right? And their relationship with myeloperoxidase, right? Remember for the testing, how we can test them. Go back to your notes. See, we have discussed all of that. Yes, you all are correct. These blast cells also have myeloperoxidase, guys. Myeloperoxidase. Specifically, guys, neutrophils. Neutrophils are the major ones that have myeloperoxidase, right? Mainly in neutrophils. Now, so what does this myeloperoxidase do, guys? Right? Myeloperoxidase, okay, we don't need to talk about the enzyme function here, right? Otherwise, it will confuse you all. Let me tell you all this. Myeloperoxidase in this leukemic cell. What did we say about leukemia cells, guys? True, they can go to other organs, they can infiltrate. True, they can get into the blood, cause leukostasis. What is the other third point that we mentioned? They have mechanisms to prolong their lifespan, right? And to avoid apoptosis. So what happens? What do you all think in AML neutrophils, AML related neutrophils that are now leukemic? Their lifespans are also longer and they are avoiding apoptosis. So what do you think about the myeloperoxidase concentration within their bodies? Will they be like a normal cell, or are their cell processes higher? They are producing more proteins, they are producing more enzymes. What do you all think? Usually that is the case when you talk about a neoplastic cell. Their activity is dysregulated, they proliferate, they do all these protein synthesis and all extra. In the same way, myeloperoxidase is very high in these cells, in these AML cells, right? Especially the neutrophils, but even the other ones can have. Neutrophils are the main guys, right? When myeloperoxidase in the cell is so high, guys, right? They crystallize, they join together and they crystallize, right? And this appears, you can see this in the microscope, guys, right? You can see the nucleus, and then you can see these rod-like, very needle-like structures. This is what we call an OR rod, right? AUER. These are crystallized myeloperoxidases, right? Crystallized myeloperoxidases. I have put a picture for you all, guys. Look at this. See, these are our rods. One here, right? And another very clear one there, right? These are our rods. Okay. This is due to increased amount of myeloperoxidase within these cells, and then they crystallize, right? Now this our rod is a diagnostic feature of AML. So you have to remember this, right? AML, right? Apart from this, guys, what is the other important thing, right? Are you all done? You all already know. If you look at the bone marrow, what will you see? What will you see?
Lymphoblasts.
Yeah, blast greater than, what is our criteria? Greater than 20%. Blast greater than, not lymphoblast, myeloblast, right? Myeloblast, right? Blast greater than 20%. Blast greater than 20%. Right? Here is the thing, guys. These R rods, right? Just put it as a side note. These R rods or this crystallized myeloperoxidase, if the cell that is holding them are destroyed, they will be released into the blood, right? Into blood. And if you all remember, guys, myeloperoxidases, these can give rise when they're not within a cell, when they're just released into circulation, they can induce what we call oxidative damage. Oxidative damage, right? Oxidative damage specifically to the vascular endothelium, guys. Vascular endothelium, right? Right? So in certain cases, I will mention a subtype, right? In certain cases, what happens? Some of these cells can disintegrate. They will release the R rod into the blood circulation, and they will cause vascular endothelial micro damage. And whenever there is vascular endothelial injury, what do we know? There is going to be, if there is a damage, a clot will form and seal that damage. But what happens if this is too much? This can give rise to what we call disseminated intravascular coagulation, DIC. DIC, clots everywhere, right? Because our rods are going and causing oxidative damage everywhere, right? Systemically, right? Guys, we are going through the very basic mechanisms, huh? Okay. Don't overthink today's class, right? If you all have any issues, drop me a message, right? Okay, because this pathophysiology of DIC is also very complex, especially when you're considering our rods. Okay, we are just, I just put it in 3 steps, but this is more than enough, right? Here, guys, look at this. So that's about the AML. What I want you all to know, just note, guys, put a note. There is a subtype of AML that is also required for MBBS, right? Called APML. APML, right? Acute promyelocytic leukemia. Write this down. Acute promyelocytic leukemia is a subtype of AML, APML. This one, guys, look at this. This is defined by a specific translocation. A translocation 15-17, reciprocal translocation between chromosome 15 and 17. I will just draw the basic thing what is happening for you all to understand, right? 15 and 17, let's say something like that, right? Here, okay, let's say this is 15, this is 17, and here we have one gene. I will tell you all what the gene is, and here we have another gene. Put it in green, right? So what is going to happen? There is a translocation, right? Cut it from here, and this one from here, and this guy will move here. The other one will move there. And what is the resultant? Look at this. Resultant, we will have something like this. Gene there, one gene here. What is this? Look at this, guys. This chromosomal translocation 15-17, reciprocal one. Here there are these 2 genes. This one is called PML gene, the PML gene. This one is called RA alpha, RAR alpha. Look at this. What is this PML? Promyelocytic leukemia gene. Promyelocytic leukemia gene. Right? What is RA alpha? Retinoic acid receptor gene alpha, right? Retinoic acid receptor gene alpha. Now, here's the important thing. The retinoic acid receptor gene alpha will nicely function as long as it's alone on chromosome 70. The moment the translocation happens, what happens? RA alpha comes here. RA alpha comes to chromosome number 15. This is the new chromosome, right? So this is what we call a fusion gene. PML RA alpha fusion gene. Fusion gene. When this fusion gene is formed, guys, retinoic acid receptors in our body get dysfunctional, right? Retinoic acid receptors dysfunctional, completely dysfunctional, right? What is retinoic acid, guys? What is our retinoic acid? Huh? Yeah, vitamin A, vitamin A, right? So now what is happening? Can we utilize vitamin A in the body? No. So there will be manifestations of vitamin A deficiency. Beyond that, when we consider the blood, right? Vitamin A is absolutely essential, guys, for neutrophil development. Neutrophil development. Now, neutrophil development, guys, happens in several stages. We drew dotted lines. Remember, we drew dotted lines. Those dotted lines, it goes something like this, guys. Just write it down. Just for the neutrophil we'll talk about, we have the myeloblast, right? Myeloblast develops into what we call a promyelocyte. That develops into a myelocyte, right? That develops into a metamyelocyte, right? Then we go to what we call a band neutrophil, and finally we get the mature neutrophil. So this is why we drew dotted lines at the start, guys, because we didn't want to write all of these, right? For neutrophil, this is the stage. And specifically, guys, retinoic acid is absolutely essential for this stage, right? Vitamin A is absolutely essential here. Promyelocyte maturation into a myelocyte, right? Promyelocyte going to myelocyte, we need vitamin A, right? So what is happening when we have a Ra alpha mutation? Now vitamin A cannot come. What is happening? From here onwards, cell arrest, right? The cell will not progress further. So what is happening? Promyelocytes start accumulating, right? This is what is the subtype, guys. Acute promyelocytic leukemia, right? This is the subtype. Okay. Right. Now, what do I want you all to know here? In APML, guys, right, our rods, AUER rods, are very, 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 very high in number. Very, very, very high in number. How do these patients present to you? Present to you clinically and present to you in your question papers. How? Tell. DIC, almost always APML comes with DIC, right? APML, not AML. AML, yes, there is a chance to develop DIC because of the R rods. APML specifically, R rods are very high, right? So they almost always present with DIC. And then, what is the other point I want you all to know? Treatment. How do you treat this? How do you treat this? It's a you all might not get it on the first case. This is called, guys, it's a form of vitamin A. Now what happens, guys, when this retinoic acid receptor is dysfunctional, its structural form changes. That's why normal vitamin A cannot come and bind, right? So therefore, we can, for treatment, we give something called all trans retinoic acid, right? This is also vitamin A. The structure is a little bit different, and these can come and still bind to those receptors, right? All trans retinoic acid, vitamin A. Now, I have come across some questions, guys, right, where they say APML can be treated with all trans retinoic acid. That is true. There are some stems, right, that say APML can be treated with vitamin A. For those also you have to put true, right? Because they don't expect you to know all this knowledge about all trans retinoic acid, what is happening in the genetic level, what is happening to the receptor. They don't expect you to know, guys. So for MBBS level, if you remember APML can be treated with vitamin A, that is enough, right? The actual thing is all trans retinoic acid. But for most question stems that I have seen, they just tell you all trans APML can be treated with vitamin A. If that is there, put it as true. For your MBBS level, that is true. Okay, right? Right. And then, so what did we say? AML and APML both can come with DIC, but it's most common in APML. Now, if you get a question, patient presenting with DIC, it's very difficult to distinguish from the question information. They're asking the most likely diagnosis. You have both APML and AML in the answer. Go with APML, right? Okay, most likely diagnosis, right? Okay, then guys, we'll come back to our AML. That was the subtype we talked about. Come back to AML treatment. How do we treat this, guys? Supportive is exactly the same as ALL. Same as ALL. Okay, supportive therapy, same as ALL. Nothing different there. The remissions are also same except for induction, guys. Except for the remission induction. Remission induction, there is a more preferred drug for AML called daunorubicin. Daunorubicin, right? Okay, daunorubicin. Okay, everything else is same, right? Remission, consolidation, remission maintenance is same. But here, just remember, there is no testicular problem or CNS problem like in ALL. Okay, that is only for ALL. That one very important to remember, the testicular and the CNS problem. AML, nothing like that. And here, guys, another thing, remission maintenance. Maintenance usually very short or not required sometimes. Not required. Why? Relapses are rare. Relapses are rare. Okay, remission maintenance. Usually, guys, once the patient goes into remission, we can give maybe 6 months of remission maintenance and then stop. Or sometimes, depending on the patient's health status and everything, we don't even need the maintenance sometimes. Relapses are rare for AML. Okay. Everyone clear about AML? That is AML. So we are done with the acute leukemias. Acute leukemias. All good. Give me a thumbs up. Show me some faces. Guys, only 3 cameras are turned on. Show me your faces. Today's chapter is a little bit different, right? In terms of how we approach it. I usually prefer to make nice stories out of lectures, but this one, quite difficult, right? But this is more than enough, guys. For your MBBS, we'll talk about the summary at the end. Don't worry, right? Okay, we'll take a 15-minute break, come back to the chronic, and then we'll be done. 15-minute break. Right. Are we back? Huh? No? No one's here? Huh? Guys, turn your cameras on. Let me see your faces. Right. Okay. Now we are going to take the discussion towards our chronic leukemias. Let me share the screen. Another thing, just before we move on to chronic leukemias, right, guys. So students from other universities, I'm not sure. So my university, students from my university, when you all are taught leukemias in 5th year, you all will be asked questions from this FAB classification, right? Other universities, I'm not sure if they make you study this, but basically it's just memorizing it, right? It's just memorizing, nothing else to do. If your university requires, if your new syllabuses require, in those days when we were doing, we had to memorize this. There were some questions that came from this. Basically, they want you all to know this M3 is the APML. APML. If you all remember that, it's enough. M6, M7, if you all can remember, just try to remember. Other universities, I don't think. Tarinda, what about you all? Do you all have this FAB classification?
I don't know exactly.
Okay, not yet. No, okay. Just check if you all have to learn it. Just there is nothing else to do other than memorize. So students from my university, if the syllabus is still unchanged, we all will have this. It's just a classification for the AML, right? Nothing special there, right? Right. Now we will come to the chronic leukemias, guys. Chronic leukemias. Now, the moment you all hear the word chronic leukemias, what should come to your mind? What do I want you all to think about? What do you all feel? What do you all think? Anything that immediately comes to mind?
Lymphocytes.
Okay. Something a bit more. What? Blasts in the bone marrow. Blasts in the bone marrow. High or low? High or low? Low. Blasts in the bone marrow are low. Most of the time, less than 10%. Right? Almost all the time, they're less than 10%. Right? We will see some exceptions where the blast increase. That's a special case. I will talk about that at the end. Right? So chronic leukemia, the first thing I want you all to know, If you look at the bone marrow, blasts are less than 10%, right? Now, what are some basic points about this chronic leukemia, guys? Insidious onset, right? Insidious onset. So very slow onset. Even the manifestations take years to develop, right? And even when the manifestations develop, guys, you don't suddenly see an anemia. You don't suddenly see thrombocytopenia overnight, right? No, little by little by little, right? You will see the manifestations getting progressive, rather, we could call it, right? And the malignant cells here are not blasts. That's the next thing. Malignant cells are not blasts, not blasts. So they are not fully differentiated. They're somewhere in the middle, somewhere in the middle. That's what we're talking about, right? So we have two types again, right? We'll be talking about both of these, CML and CLL, right? Okay. And since they are a cancer of the chronic nature, right? They have the chronic nature. So insidious onset, slow onset, progressive onset of symptoms, and they will have these constitutional symptoms of cancers that we generally see, guys, in other types of cancers. For example, weight loss, right? Nausea and vomiting, right? Night sweats, right? These kinds of constitutional symptoms of malignancies will be seen because of their chronic nature, right? And apart from these, yes, we can again see anemia, thrombocytopenia, neutropenia. These things can be seen definitely, but not developing suddenly, right? Not within a few days, not within a few weeks, right? Takes a long time, right? Now, so I'll just paste this one here again, right? Just to reboot your memory. This is what we said, right? So when I say, we'll start off with the first one. Our first subtype for today is CML, chronic myelogenous leukemia. Now, when I say chronic myelogenous leukemia, where is the problem? Somewhere here, right? Somewhere here, but more specific, don't color it like that, because why? We said this is a leukemia. This is a problem with the white blood cells. So more specifically, guys, it is mostly seen in these, and out of these also, guys, granulocytes are the most affected one. Almost always. These monocytic leukemias are very rare. Very rare. Okay. So for MBBS purposes, we are not even going to talk about monocytic leukemia, right? We are only going to talk about this neutrophil, basophil, eosinophil, granulocytic problems, right? Okay. So let me put that in another color. This is what we are going to discuss, right? Guys, when you're coloring this, color it with those dotted lines, because those dotted lines are important. That shows that there are others and not just one cell type here. Okay, there are somewhere in the middle, right? Okay, right. Now, if we look at this, guys, so what did we say? Most commonly in granulocyte. Therefore, guys, another name that comes in question stems, and for me at least, it was very confusing in the start because I didn't go to this depth when I was starting this, especially the first time you're learning about leukemia. It seems like a explosion, right? Another in question stems, another word that comes is, so we are also known as chronic granulocytic leukemia. When you see chronic granulocytic leukemia, you should know that is the same thing. They're talking about CML, right? Because the question stems comes, which of the following are features of chronic granulocytic leukemia? And then you start thinking, granulocytic leukemia, what is that? I have studied 4 types. I don't know anything else, right? That's what happens if you memorize, right? So understandable. Chronic granulocytic leukemia. Now, look at this, guys. So what is happening, guys? Firstly, these cells will start accumulating in the bone marrow. They will start accumulating in the bone marrow and eventually come to the peripheral blood. So we can get a similar picture. Here's the thing. If we look at the blood picture, right? Peripheral blood, right? Put peripheral blood. Peripheral blood. If we look at the peripheral blood, guys, right? The WBC counts are often seen very high in these patients, right? WBC counts are often very high, usually in the 50 to 100,000 range. 50 to 100,000 WBC. WBC should usually be 4 to 10 or 11,000, right? Usually 50 to 100,000 range, right? So what is this called, guys? We call it leukocytosis. Now these leukocytosis, are they, what do you think, 0% in functionality, or maybe some amount of functionality is there? Yeah, second option. No, they have, you can show some resemblance, some amount of functionality, right? So leukocytosis is there, right? And as the disease progresses, we all know with progression, what we'll have disease progression, since especially this is chronic, we will have pancytopenia. Pancytopenia. So basically our anemia, neutropenia, thrombocytopenia, these three can be there, right? But not very prominent, not very prominent, right? Then here, guys, now look at this. We have this leukocytosis. Now, as a physician, right, it is very important for you, because the patient will come with a blood report. It is very important for you now to further diagnose if this is a leukocytosis due to the leukemia, or if it is something what we call leukemoid reaction. What is leukemoid reaction, guys? What is leukemoid reaction? What is leukemoid reaction? Huh?
Increase of white blood cells due to inflammation or something.
Yes, due to infections, basically due to infections, right? This is what you get day in and day out, right? If you get a fever, you go do a blood test, WBC count will be high, right? And depending on the severity of the infection, sometimes 50,000, sometimes 60,000 can be, right? So it is up to us now to differentiate between the two. How do we do this, guys? Not up to the physician, not up to the doctor, but we will send it to the lab and they will do it for you. But under MBBS, you should know what is going on, right? How do they differentiate this, right? There is something called LAP, leukocyte alkaline phosphatase, right? Or in some books, in some newer editions of books, they replace the L with N. That is for neutrophil, because this alkaline phosphatase is mainly secreted by the neutrophil, right? So neutrophil alkaline phosphatase, NAP or LAP, both are the same. What is this, guys? What is this? Look at this. Normal, if you look at a normal neutrophil, I am talking about a non-cancerous neutrophil, a normal non-cancerous neutrophil. Normal non-cancerous neutrophils, guys, they produce this alkaline phosphatase. They produce this LAP or NAP, right? Okay. Now, what happens in the CML neutrophil, right? This NAP or LAP production is very, very, very low. Why are we saying it's very, very low? We said they are not absolutely dysfunctional cells, but they are not as good in terms of functionality as the final terminal differentiation. So their neutrophil alkaline phosphatase is low. So if you get a patient with leukocytosis, especially if they're in the 60,000 range, you can do this test, right? You can check for the LAP, check for the NAP score. There is a scoring system, right? So let's just write this. If leukocytosis, do the LAP or the NAP, same thing. If the score is high, that means what, right? They are normal neutrophils. That means that is a leukemoid reaction, right? Moid reaction. If their LAP score is low, right, that is a possibility of leukemia. Obviously, there are other further testings to do, but what you can exclude is that the patient is not having an infection. That elevation of WBC is due to something else, right? Due to something else, right? Okay, understood this? Right. Then etiology. Right. What is the etiology? Unknown.
No.
Yes, right. Very happy to say that, no? Unknown, right? Okay, but for CML, we have some prominent risk factor, a prominent genetic risk factor, which is the translocation 922, right? Our Philadelphia chromosome. Absolutely. 95% of the cases of CML, chronic myelogenous leukemia, will have this translocation, right? What is this? Look at this, guys. Look at this. You all can draw this. So we'll look at chromosomal 9. Chromosomal 9 and 22. 9. So 9 and 22 is quite far away. So the size difference would be a little bit more highlighted. 22 would be obviously smaller, right? Something like this. This is 9. This is 22. On chromosome 9, guys, in the Q arm, we have this gene here called the ABL gene, ABL, ABL, right? ABL, right? And on normal chromosome 22, what do we have? We have the, again in the Q arm, in the long arm, we have the BCR gene, BCR gene, right? Now, this BCR and ABL, their functions, we don't need to know. They have a multitude of functions, right? They do their own work. The problem happens with the translocation. What happens, right? With the translocation, right? Resulting, we will get a new chromosome number 22, right? The new 22, guys, it will have BCR and ABL, right? This is what we call BCR ABL fusion gene, and this is chromosome number 22. The new name given once this gene, once this fusion gene is formed, chromosome 22 is then called Philadelphia chromosome, right? Philadelphia, so it was found there, Philadelphia, right? So this is called the Philadelphia chromosome. Now, this is the guy that is going to cause the problem. This Philadelphia chromosome or this BCR-ABL fusion gene, guys, this thing, it codes for a specific protein. These are all genes, no? They code for proteins. This guy, once they're joined together, this fusion gene, it codes for an abnormal tyrosine kinase, right? An abnormal tyrosine kinase, right? And here there are some highly molecular level detailed mechanisms, guys. This one, of course, it is explained scientifically. There are enough explanations, but the thing is definitely not MBBS, and it's past PG also. Okay, right? So it's very complex. End of the day, what does this abnormal tyrosine kinase do? This is all I want you all to know. It allows WBCs that have that fusion gene, right, to avoid apoptosis, right, thereby increasing the lifespan. Right? This is the hallmark, right, of CML, guys. Why 95% of the cases come with this translocation? So this is the hallmark, right? Right. Now, based on this, as a doctor, as a scientist, right? If we want to treat this, what can we possibly or probably do? Just based on this information, it's more than enough.
Gene therapy.
Sorry? Shashank, I didn't hear you.
Gene therapy or like bone marrow transplant.
Right.
Hmm.
Right. Now, okay, true. So, okay, bone marrow transplant. Yes, there is a place. Something more simple, something more obvious here. Who is causing the problem? True, it's the Philadelphia chromosome, but what is the actual guy causing the problem? The protein that it codes for. The BCR-ABL gene, it codes for this abnormal tyrosine kinase. He's the fellow doing the problem. So, what can we probably do? Huh? Tell. Huh? No?
Tyrosine kinase inhibition.
Excellent. Tyrosine kinase inhibitor. For the treatment, we can try to inhibit the tyrosine kinase. What is this? Imatinib. Go back up. Now you all know the mechanism of where did we write that? Yeah. Go here, right? Here. Imatinib. If the Philadelphia chromosome is positive, we said we are going to treat them with imatinib. Now you all know why. It's a tyrosine kinase inhibitor, right? And it can inhibit this protein product. Actually, guys, right? This imatinib, I will mention again when we come to the treatment, right? This one, when you give imatinib to a Philadelphia chromosome positive patient, right? It goes and inhibits the tyrosine kinase, and it has upstream changes as well. Upstream changes. What do I mean, guys? At one point, let's say you start the treatment today. You give the patient, put the patient on imatinib today. Depending on the severity of his disease, right? At one point, let's say after about a year, when you check, he will not have BCR, he will not have Philadelphia chromosomes anymore. Chromosomes will be gone, right? Not detectable, right? So it is a tyrosine kinase inhibitor, but it has upstream changes as well on a molecular level, on a genetic level, right? So that is important. That comes in your MCQs, in your questions, right? Imatinib after treatment, after successful treatment, will reduce the amount of Philadelphia chromosomes present in the patient. True, very important, right? It is not just the tyrosine kinase inhibition, right? It will completely wipe out Philadelphia chromosomes, right? Okay, clear about this, right? Okay, now we'll come to the diagnostics of this. Diagnostics of CML. Look at this, guys. Again, as I said, right, the clinical features, insidious, right? Weight loss, night sweats, right? Anorexia, right? They can have constitutional fevers, right? These kind of manifestations can be there, right? Late in the disease, guys, they can have any feature, write this down, any feature of pancytopenia, especially slow onset, not sudden overnight thrombocytopenia. They don't go to sleep and suddenly wake up with purple spots in their body. No, slowly, little by little, progressive, right? And here is another thing, guys. Often when these patients present to you, because now look at this, do they have an acute presentation when they come to meet you as the doctor? No, right? Most of the time, this is actually an accidental finding on a blood report, right? And if they present to you, you do the physical examination. Most of the time, guys, there is massive splenomegaly, right? Now, this is not a pathophysiological mechanism. It's not that the splenomegaly is very high in this patient. It's just that it develops little by little over a long period of time that the patient doesn't actually notice. He thinks just his stomach is just a little bit bigger. But when you do the physical examination, you can palpate the spleen, right? Often very massive, guys. Specifically, if you draw the abdomen, right? Something like this, no? Midline somewhere here. Umbilicus there. This splenomegaly, guys, it often crosses the midline, from the left side, and often, right, greater than 8 centimeter below the costal margin. So this is massive splenomegaly, right? Okay. So how will the patient come to you? So they will just say, okay, my stomach, maybe I have noticed a little bit big. They don't know it's splenomegaly, right? Especially in our South Asian regions, they will say, doctor, I eat a little bit more this time. Christmas just finished. I had some, they will tell you all types of stories. They will give some other information. They will say, doctor, specifically this left side feels a little bit heavy, right? Write this down, left side a little bit heavy. Dragging sensation in the left side, right? Tightness in the left side of the stomach, right? Another one. What is another very important one with massive splenomegaly? Based on the structures that are here on the left side. Who else is here? Who else is here? Stomach. Early satiety. Write that down. Very important in your questions, right? Early satiety, right? Early satiety. They feel full. They eat a little bit. They feel very full. Why? Spleen has acquired a lot of space of the stomach, right? Early satiety, right? So left side feeling heavy, dragging sensation in the left side, tightness in the left side, right? Stomach, stomach. Okay. Stomach area, hypochondriac area, left hypochondriac area, and early satiety, feeling full often, right? Bloating, these kind of manifestations, right? Right. Then we'll look at the labs a little, guys. The labs. If you look at the lab findings, obviously one of the main ones is PH chromosome. The Philadelphia chromosome will be positive, right? There is the main one. This is the main one, right? Philadelphia chromosome positive. Then, guys, we can have what? We said leukocytosis. Leukocytosis can be there, right? Here, guys, now what is happening when the WBCs are very high in number? The leukocytosis is there. That can result in leukostasis. Leukostasis, right? So a large number of blood WBCs in the blood that is causing viscosity to increase, and therefore the blood flow rate and everything increases. Therefore, the leukocytes, they start accumulating within the blood, right? Stasis, there's a stasis. Now this one, guys, can give rise to some specific manifestations, especially when it is a bit severe. When this leukostasis happens in the pulmonary circulation, right? What can we have? We can have hypoxia, shortness of breath, and pulmonary lung infiltrations, guys. Why? When the blood is not flowing rapidly, right? Whatever leaks out will not nicely be taken back in, right? So the tissue fluid will start accumulating. They can have edema, pulmonary edemas. So they can result in hypoxia, shortness of breath, right? Again, always remember, not overnight developing, right? What they will say, doctor, since the last month or two, I've been having a little bit of shortness in my breath, right? Remember, chronic. Then, guys, CNS. CNS, again, when there is leukostasis, headaches, right? Headaches as the blood viscosity increases, right? Confusion sometimes if it is very serious, and Glasgow coma scores can be low, guys, right? The Glasgow coma scores can be low, right? Headaches are the most common. And then, guys, ocular, if you look at the eyes, this can also cause problems there, right? Papilledema, and if it is severe, right? If the viscosity is so high, right? They can cause reduced vision, right? Sometimes retinal hemorrhages, right? Retinal problems, retinal hemorrhages, right? Okay, due to the loss of nutrition, as the blood is not flowing, right? So nutrition is not, requirement is not met. So eventually there's going to be damage, right? Retinal hemorrhage. So all of these can happen, right? Okay. Right, guys, here in the labs, one of the first things I forgot to mention, but you all already know, blasts. How much in the bone marrow? If you look at the bone marrow, less than 10 less than 10%, right? Don't forget that, huh? Philadelphia chromosome, yes, right? Remember our lap score, guys, or the NAP score? Nowadays, NAP and lap, guys, not commonly performed because this Philadelphia chromosome is a good enough marker, right? It's more than enough. So this lap or NAP, not commonly done, huh? Not commonly done, right? But again, can be done, okay? Right. Then, guys, so those are the main diagnostics. Next, we have to talk a little bit about the stages, guys. Stages, right, of CML, because unlike the other leukemias, right, these ones have some very specific stages. Look at this. First one is called the chronic phase. Chronic phase. This one takes a long time, guys, usually 5 to 10 years. 5 to 10 years. Often asymptomatic, most of the time asymptomatic, right? Asymptomatic. On routine check, you can find WBC elevated on a routine check, right? For some other thing, right? Then they can have any manifestation of pancytopenia, blasts. This, if you at this stage, guys, it is highly unlikely that you will do a bone marrow aspirate. But due to some other thing, let's say you did a bone marrow aspirate, right? Blasts will be less than 2%, right? Less than 2%. That low. It's almost normal. Almost normal, right? Then we come to the second phase, what we call the accelerated phase. Accelerated phase. Now, this is after the initial 5 to 10 years, guys. This one usually lasts a few months. Few months. Now, it can vary obviously from patient to patient, 2, 3, sometimes 4 months, right? And here, the WBC or increase, or what we call leukocytosis, is much more rapid. What do I mean by that, guys? Let's say we tell the patient, okay, bring a blood count today, right? Let's say he will show, let's say 50,000, right? And then within almost another 2 weeks, you tell him to come again, 70,000, another 2 weeks. Now the initial phase, 5 to 10 years, throughout the 5 to 10 years, little by little by little, it increased. Now it's getting a little bit accelerated, right? Rapid. And here, guys, usually towards the accelerated phase is when most of the patients are diagnosed, guys. At this stage is when diagnosis is common, right? Common, because they start clinical manifestations as well here, right? And once diagnosis is done, guys, right? This is where we obviously initiate treatment as well, right? Some percentage of cases, you can write this in red. Some percentage of cases in the accelerated phase will have treatment failure. And that will lead, guys, to the final phase, what we call the blast crisis. Blast crisis. Now look at this. Chronic myelogenous leukemia. Do we have blasts here? Do we have blasts here? No. But this phase is called blast phase. What do you think is happening here? What do you think is happening here? Or the blast crisis, what is happening here? Any guesses? Guesswork, guesswork. Huh?
Is the bone marrow tries to compensate.
Not really. Here, by this time, guys, we've already reached some degree of bone marrow failure, right? So it's difficult to really compensate here. Here, guys, nothing, don't think too much, right? Don't try to think how this is happening, but I will tell you all what is happening. What is actually happening here is, guys, the CML transforms into acute leukemia. This is a transformation. Most often it transforms into AML rather than ALL. But having said that, doesn't mean it cannot transform into ALL. Sometimes, rarely it can, but most of the time it transforms into AML. AML. Right? This is what we call the blast crisis, guys. Now, so this is basically the defect the genetic defects, the environmental defects, the exposures, these are moving further up in the cell lineage, guys. That is why this is happening, right? So the sites are now becoming blasts. So the problem is starting there itself. This blast crisis, guys, I want you all to know, is characterized by lymphadenopathy, right? Lymphadenopathy, characterized by lymphadenopathy. But what do we know? Lymphadenopathy can usually happen in a lot of cases. It's not very specific. Now, here's the good thing for us. This is how it comes clinically and in your questions. How does it come, guys? A previously known CLL patient, right? You do a bone marrow biopsy, blasts are now greater than 20%. The patient on physical examination shows lymphadenopathy. What is your diagnosis? Blast crisis, right? Okay, right? This is important, right? Comes in your questions. Okay, now come to the treatment of chronic myelogenous leukemia, CML. What is our first line? Tell me. First line, tell me. Huh? What is our star drug? Huh? 95% of the cases of CML show what? Show what? What genetic defect? Guys, CML, 95%. Philadelphia chromosome. So don't we have a drug against that? Don't we have a very good drug against that?
Imatinib.
Imatinib. This is our first line. Imatinib. This is the star drug, guys. Star drug, right? Okay. Imatinib will be able to induce remission, right? In 80, 90% of the cases, right? Before this imatinib was found, guys, mortality rates of CML were quite high, right? 40, 50%. Once imatinib came, mortality rates dropped 10 to 15%, right? See the drastic difference, right? This is a star drug, star drug. Okay. Then, just note, guys, now what is this imatinib targeting? It is a tyrosine kinase inhibitor. At the same time, we said there can be upstream changes where it reduces, completely erases Philadelphia chromosomes out of the patient, right? Just note, guys, sometimes, rarely, some patients, apart from the Philadelphia chromosome, right, apart from the BCR-able translocation, 922 translocation, they can have some other gene mutations that prevent imatinib from working. This is rare. This is rare. Some cases are imatinib resistant. Imatinib resistant. Why? They have some other genetic defects. For them, guys, we have second generation tyrosine kinase inhibitors. The example I want you all to know for MBBS level, dasatinib, right? Dasatinib, right? If imatinib fails, we have a second option. There are actually more than 5 options, guys, right? We have a lot of options, but for our level, dasatinib, if you all remember, this is a second generation tyrosine kinase inhibitor. This has higher potency than imatinib. We can use this, right? Dasatinib. It's very rare that they are imatinib resistant, but possible, right? Then, guys, there is another drug, right? Hydroxyurea, not very important. Hydroxyurea, right? This is again, right? I don't want you all to know the pharmacology, right? It is a ribonucleotide reductase inhibitor. Not necessary. If you all can just remember, it inhibits DNA synthesis, that's more than enough, right? So this has direct cytotoxic effects, guys. Direct cytotoxicity. If you all remember, even in multiple myeloma, we said we don't, for multiple myeloma, do we use a lot of cytotoxic drugs now? For multiple myeloma? Huh? We really don't, guys. Multiple myeloma, we have some good treatment options available, right? But here, this hydroxyurea is cytotoxic. Cytotoxic drugs, what do they come with? Huh? Cytotoxic drugs. What's the problem? No idea? Guys, be interactive, be interactive. Huh? Talk with me. Huh? What do cytotoxic drugs come with? A big list of side effects, hair loss, loosening of teeth from the gums, right? So problems, right? So anyway, we have a good first line drug. For most of the cases, imatinib is more than enough, right? And for our MBBS level, imatinib, CML, imatinib, right? Now, what do you think of this statement? For chronic myelogenous leukemia, early treatment is absolutely essential. True or false? For CML, early treatment essential. True or false? Think of what we have talked about now and tell me. What do you think? Let me tell you all this, guys. That will probably make you all easier to answer this question. When we consider acute leukemias, right? Acute leukemias, without treatment, the chances of survival are about 5 weeks. 5 weeks, you're gone if you don't get treatment for acute leukemia after being diagnosed, right? Now I'm asking you, chronic myelogenous leukemia, is it essential for us to treat immediately or as soon as we diagnose, or is it essential? Early diagnosis and treatment, is this essential? What do you all think?
No.
Why not?
Because imatinib can resolve.
No. I'm asking. So early treatment with imatinib. Is it essential or not? Imatinib is the first line, correct? I'm asking the early treatment. Or can we allow the disease to progress for a while without any problems and then treat? What do you all think? These are MCQs.
Early treatment is better
Early treatment better. Why? Why? Good.
because if it can progress to acute leukemia and then it's difficult to manage.
Treatment failure.
Excellent. Right? What is the risk, guys? Blast crisis. Right? Blast crisis. If this is blast crisis, guys, you all can still see me. You all can hear me, right? All good? Right. If this is blast crisis, what is this? This is an acute leukemia. An acute leukemia left untreated, maximum survival 5 weeks, right? So what should we do? Chronic myeloid leukemia. This is your MCQ stem, true or false? Early treatment is essential for CML, right? Early treatment essential. Now, why I am telling this, guys? Now we will see when we go to CLL, right? Chronic lymphocytic leukemia, we will see early treatment is not an absolute essential there. We will see, right? For this one, CML, you should know early treatment is necessary, otherwise blast crisis. If we go blast crisis, guys, even imatinib, very difficult, even with imatinib, even if they're pH positive blast crisis, doesn't matter, difficult. Acute, very acute. Okay, understood that? Understood, all good. Right, we are done with CML. Now we are coming to the final one for today. Chronic lymphocytic leukemia, CLL, right? Right, CLL. Okay. This one, guys, remember the L, we changed it to lymphocytic. What does that tell you? Bone marrow blasts less than 10%. Less than 10%. Again, no blasts here, right? because it's chronic in nature. Chronic is somewhere in the middle. Only the acutes are the blasts, right? Keep that picture in your mind. Now, let me take our diagram again. Our problem, let me take this part. We don't need the rest. Delete this. Right, take this. Right, our problem here, guys. Our problem here is something here, right? Some problem somewhere here, right? Here's the important thing I want you to know. For MBBS and for almost all the time, CLL is a B cell leukemia. Only here. No T problem. MBBS, not at all, right? And even in real life, guys, right? 90, 95, 97% of the cases, B cell. So MBBS, we don't even consider T for CLL, right? This one, guys, this one, what did we say? The age range for CLL is usually greater than 65 years of age, so very elderly individuals, and this is the most common adult leukemia. Most common adult leukemia. Okay. So now you all know what is the most common child leukemia? ALL. Most common adult leukemia? CLL. Okay. Both lymphocytic types, right? The lymphoblastic for the acute, lymphocytic for the chronic. Right. So again, like we discussed, since this is chronic, guys, we can have the insidious onset again, and we can have those the manifestations of the chronic nature, the weight loss, right? Anorexia, all of those things can be there. Apart from that, guys, often asymptomatic at the start. If you're just same to the CML, same as CML, fever, night sweats, all those things can be there. Here, this is what we call, guys, a neoplasm of naive B cells. Why we say B cells only? Because T we don't consider now anymore. B cells, so we don't consider T anymore. So this is a malignancy of naive B cells, right? They're not blasts, not blasts, remember. Now, these naive B cells, guys, just some features of them, they resemble the fully differentiated or the mature B cell, right? Naive B cell, they resemble the mature B cells, right? But what do we know? Functionality is less. And what I want you all to know, guys, these are more fragile. They are very fragile cells. What do I mean by very fragile, right? Here's the picture you can get into your head. Just getting a patient's blood sample and putting it onto a slide, right? Putting it onto a slide to view under the microscope, these naive B cells of CLL get broken down. They get broken down. Just getting the sample onto a slide to view under the microscope, right? So these are very easily damaged, guys. Very easily damaged. And often when you view under the microscope, we see these damaged B cells, which we call smudge cells. I have put a picture for you all, guys. Smudge cells. Yeah, here we go. These are, guys, these are basically cells where the cell membrane has been damaged and the cytoplasm starts leaking out. If you all have used Photoshop, you all know this smudge tool, right? If there is a thing, you can smudge it around it and it will sort of like it's smudged. I don't know how else to explain it, right? Smudged, right? So basically these are the cytoplasm just leaking out around the cell, guys. These are what we call smudge cells, okay, right? So these are a feature of this CLL, smudge cells, right? Then look at this, guys. Now, naive B cells, their functionality is reduced, but not 0%, right? So when we say functionality of a B cell, B cells, you all know, they progress one of their major functions is what? After obviously maturation, they help produce antibodies. So in here, guys, in CLL, another very important feature, right, is hypogammaglobulinemia, right? Now, do you all have any question coming into your heads, into your minds? Any question you want to ask me? No questions? No confusing points now? Anything?
Shouldn't it?
Sorry?
Okay, never mind.
No, it's okay. If you have anything, anything. Now the question would be, guys, right? Now in CLL, the problem is here. And we are saying there is hypogammaglobulinemia. What about ALL? In ALL, where was the problem? ALL, the problem was here, right? So the question that should come to your mind should be, if a further upstream one is being dysfunctional, can't that also result in hypogammaglobulinemia, right? Agreed? Valid question. Okay. What do you all think the answer is? What do you all think the answer is?
Yes.
Yes, that also can result in hypogammaglobulinemia. But did we mention it? Did we talk about it? Is it a prominent manifestation? No. Why not? Why didn't we talk about it? Why? Think. I have to start thinking. Think of the time period, right? Acute leukemias, they acutely develop, right? We said days to weeks. Chronic leukemias, they take time, sometimes years. Now, in acute leukemias, we have other prominent manifestations that develop quickly. They will have anemia quickly developing within a few days, shortness of breath, thrombocytopenia, right? Spotting all over their body, right? Hypogammaglobulinemia, guys, what does it result in? More frequent infections. This is what it happens, especially bacterial infections, right? Now, in an acute leukemia, do you think you have the time to notice this frequency of infections within a few weeks? No. So hypogammaglobulinemia, guys, it can happen in acute as well, right? But it's not a diagnostic point, and even the patient won't notice, even you won't notice, because the time period there is much smaller, right? Here, chronically, when this is happening over a long period of years, patient will say, doctor, now I notice I often get sick. I often get coughs and fevers with phlegm, bacterial, right? Something, right? So that's how they will present to you. Okay, right? So frequent infections, specifically bacterial infections, know the difference. So in CLL, this is a prominent feature. CLL, ALL, also under the picture it is happening, but we don't notice it, right? Okay, right. So for your exams, hypogammaglobulinemia is seen in ALL. False, false. Don't go to think too much. Think, underneath this is happening. Yes, it is a possibility. Oh, no. False. Okay. Hypogammaglobulinemia is CLL. Right. This is the issue, guys. This is why you have to strike the balance between reading too much. See, I also have this issue. Right. Specifically when it comes to university exams, last month, do papers only. Don't go to read Harrison's Kumar and Clark. Okay, right. Then next thing, immune system. Look at this. When there is hypogammaglobulinemia and all of these going on, these naive B cells, guys, what did we say? Now naive B cells in the circulation are going to increase. In the circulation, naive B cells start increasing. Their functionality is less. Our immune system, what do you think they will do? This properly non-functioning, sometimes non-functioning cells are going all around the body, wasting space, wasting resources. What is our natural immune system's natural response towards this? Huh?
Destroy.
Try and destroy them. Try and destroy them, right? So here, guys, our normal immune system can produce antibodies against them, basically produce auto antibodies. Now, what I want you all to know, these auto antibodies are not coming from neoplastic cells. This is your normal immune system responding to these abnormal cells in the circulation, right? So they produce auto antibodies, guys, and these auto antibodies can cross react with RBCs, giving rise to what? Giving rise to what?
Hemolytic anemia.
Autoimmune hemolytic anemia. Those who came to my lecture, tell me, this is with regards to relation to lymphomas and leukemias, especially chronic lymphocytic leukemia. This is warm AIHA or cold AIHA. But it's there in your notes. This is warm AIHA, warm autoimmune hemolytic anemia, right? You all know the difference between warm and cold and all of that, right? If you all can't remember, no problem. Just go and look through the note, no issues, right? Right. Then, guys, diagnostics, again, you can have weight loss, fatigue, fever, lymphadenopathy, all of these can be there, hepatosplenomegaly, all of these can be there, right? Clinicals, right? If you do the labs, what can we see, right? In the labs, right? If you look at the full blood count, you do the full blood count, we can see leukocytosis. And as per our MBBS and most of the cases, what type of cell is this?
Prashan,
Yes.
since there is hypogammaglobulinemia and there are production of autoantibodies, like will the AIHA be to a like lower extent than
To a
normal?
minimum.
Yeah.
Yes,
Yeah.
possible. Yes, possible. And the treatment will probably be easier. That's a good hypothesis to make. But for MBBS level, don't overthink. Just know what I want you all to know. CLL, warm autoimmune hemolytic anemia, is there. The severity can be less because of the hypogammaglobulinemia and all of those things. True, right? That is a good hypothesis. That's good, right? Right. So in the full blood count, what do we see? Leukocytosis. What type of cells here, guys? As per our MBBS and as per our major findings clinically, what type of WBC is high here?
Neutrophils.
Neutrophils is myeloid. This is, we are in the lymphoid side now. B cells. See, this is why I said that picture is very important. It's difficult to get that picture in one day into your head. Try looking at it over and over again. Once you get that picture to your head, very easy. Leukemia becomes much easier. The initial hematopoiesis. Try to get that into your head. Right. So B cells are going to be high. Now, tell me this. B cell markers are generally CD numbers of what? What values? CD usually what for B cell?
10 or higher.
Yeah, 10 and
10
up, the
plus.
higher numbers, right? 10, 11, 12, 13, 20, 21, 23, those things, right? So here, guys, we can see B cells with those high numbered CD markers. Important, very important, and probably most confusingly, right? We have some B cells in CLL which are CD5 positive. This is a hallmark feature of CLL. CD5 is usually a T cell marker. But in the case of chronic lymphocytic leukemia, there are B cells. They show all the CD23, 21, all those high numbers they can show, but they specifically show CD5 positivity as well, right? This is important, guys. This is important. Okay. Why this happens? How this happens? Huh? No one knows, right? It's an issue. It's a problem, right? Okay. Then don't forget when we come to the lab. So that point, I hope you all understood. Don't forget when we come to the lab, smudge cells, smudge cells, smudge cells, right? How to remember the smudge cells coming for CLL? Crushed little lymphocytes. If you can remember it like that. CLL, they're crushed, right? Little lymphocytes, smudge cells, smudge. Now look at this, guys. This one. This takes a long time to develop. Did we see any very serious manifestations? True, we can have some frequent infections, right? They can have autoimmune hemolysis sometime, right? But chronic in nature. And there is no transformation like a blast crisis or anything like that here, right? Nothing here. Because of that, guys, when we look at the treatment, majority of the cases of CLL, majority, right? Observe plus routine checks. Observe plus routine checks, right? Usually, right? Not necessary, right? When do we treat it, guys? We treat only if, right? Write this down. So there are some conditions, right? We see rapidly progressive bone marrow failure, and especially, guys, what I want you all to know, uncompensated. That means what? The bone marrow, now you all know anemia can develop. But if our bone marrow is still capable of keeping the hemoglobin level, producing more RBCs, keeping the hemoglobin level up to about 8, 7, 8, 9, still it's okay. But if it is uncompensated, hemoglobin starts rapidly dropping, bone marrow failure severe, right? So same with thrombocytopenia, these kind of things, right? So if it is rapidly progressive, then yes, we have to treat it. Then, guys, second one, if we have increase in the numbers of lymphadenopathy, that means more and more lymph nodes getting involved. We see more and more lymph nodes getting larger, right? Lymphadenopathy, right? Or even one single node or 2, 3 nodes that are increasing in size rapidly, right? Increased lymphadenopathy. If we see, we can go for treatment, and the same with increased splenomegaly, right? If these are happening, then yes, we can go for the treatment. And here, guys, the treatments are absolutely not essential for MBBS. They will not ask you for CLL treatments. Just for your sake, I will tell you some of them. One is rituximab, right? Rituximab, this is one of the first lines that we use, right? Then we have cyclophosphamide, right? And this third, a little bit of a newer drug, right? Fludarabine. Rituximab, how does it work? What is it? It's a monoclonal antibody. What is it? How does it work? Directed against what? Now, just thinking of the CLL disease, why do you think we are using rituximab? What do you think it goes and attacks? B cell. This one goes and attacks, guys, any cell which is CD20 positive. Any cell that has CD20 marker, this fellow will go and attack. So majority is B cells. So be it healthy B cell or a neoplastic B cell, it doesn't matter. If CD20 is there, this fellow will go and attack. Okay. So it comes with some side effects as well, right? Cyclophosphamide, how does it work? Again, a bit of a complex mechanism. Just remember, DNA and RNA synthesis inhibitor. It actually binds to them and forms cross-links, guys, between DNA and RNA, right? Just remember, DNA RNA synthesis inhibitor. This fludarabine is a little bit new. This is a DNA synthesis inhibitor, right? Fludarabine, right? Okay. Then, guys, just note, really, So for a majority of the cases, we don't even need treatment, right? So rarely there is a complication. This is rare, huh? Rare. Just note this down. This complication for CLL, right? What is this complication, guys? This is something called Richter transformation, right? Richter transformation is basically, guys, CLL converting to a lymphoma. Now, lymphoma is your next chapter. You already talk about lymphomas there. This one will convert to what we call a diffuse large B cell lymphoma, right? Okay, right? This one, guys, is diagnosed using a lymph node biopsy. Lymph node biopsy. You all will learn. So that you all will learn, guys, lymphomas, these are problems. You see them, initially you see them, right? Almost all the time you see them in a lymph node. That's why it's called a lymphoma, right? Lymphoma. Now, leukemias were what? These were usually problems of the blood itself. And then they travel to other places and infiltrate. But if you look at lymphomas, you all will talk about, right? That is a problem in the node itself, right? We all will talk about that next. Huh? Just know this Richter transformation is possible, but it is very rare, very rare. Yeah, not necessary. Right? Okay. Look at this, guys. We are done. We are done with all 4 forms. Take a new page, take a blank page, and we'll do this summary. This is the absolute essential I want you all to know for your exams, right? Take a page, guys, and draw a large box, right? And break it down into 4, right? Right? Yeah, it's not equal, but okay, close enough, right? So we'll talk about the 4 types, right? What do we have? ALL, CLL, right? For the lymphocytic ones, guys, use one color. So I will use blue, right? And for the myeloid ones, I will use red. So we have here AML, right? Okay. Guys, turn your cameras on, huh? Only the 2 cameras are turned on. Can't see your faces, difficult to teach, huh? If you're out, it's okay. Right? Kritika, Sala, huh? Turn your cameras on. Right? Okay, good. Let's take a look at this. These are the absolute essentials for your exams and for MBBS level. Write these down, guys. ALL, right? Now you all tell me, I will ask you all. If you compare, this one is mostly seen in children or adults. Unmute and talk quickly. Children, right? So first point, children. This is what I want you all to know. Then, if you look at the cell lineage, this is acute lymphoblastic leukemia, right? Mostly this is a B cell or a T cell problem. B cell, correct. B cell ALL is more common than T cell ALL, right? So it's mostly B cell. Then, if we look at the bone marrow blasts, how much of blasts are in there?
Greater than 20.
Excellent. Greater than 20%. Greater than 20%. Right? Then this is acute lymphoblastic leukemia. What is the problem we said with lymphoblasts? It's difficult to differentiate them from the myeloid side. So how can we differentiate the lymphoblast from the myeloid side? What is the marker?
TDT.
Excellent. TDT positive. TDT positive. Right? TDT positive. Right? Then we have some genetic associations. One is there is a high association with Down syndrome. Down syndrome. Then we have some chromosomal translocation. If we look at the translocation, one is the BCRA by chromosome 9 and 22. We said Philadelphia. Philadelphia chromosome, right? If the Philadelphia chromosome is positive in ALL, what is the prognosis like? Good or bad? Good or bad?
Bad.
This is
Bad.
bad prognosis. Bad prognosis, right? Bad prognosis. Then the other one, the TEL AML one, guys, I don't want you all to remember, right? If you all can remember, just remember that it is good prognosis seen in children, the TEL AML one, huh? Not very necessary. What I want you to know, the other one about remission maintenance, why in boys, you all know, it can go to sanctuary sites, the testicles, the testes, right? And that guarantees what? Longer remission maintenance, about 3 years, of remission maintenance, right? Don't forget that. That's children here. What do I want you all to know? Specifically 0 to 14 years of age. Don't forget that, right? 0 to 14 years of age. And if you look at the prognosis of adults versus children, who has the better prognosis? Children better.
Children.
Children better. Right? Children better. Okay? Children better. Right? Now look at this, guys. Look at this. CML. We'll come to CML. This one, usually adult onset. We said the age group is about 40 to 60. 40 to 60. Here in the blood, what can we see? Leukocytosis. Leukocytosis, right? And often they come with massive splenomegaly, right? This is very important for CML. CML, often massive splenomegaly. Tell me this, bone marrow blasts. Bone marrow blasts, how much?
Less than 10%.
Less than 10%. Less than 10%. Then I want you all to know there are 3 phases in CML, right? I don't want you all to be able to explain everything in detail. Just know there is a possibility of transforming into something called the blast crisis. Because of that, what did we say? Early diagnosis and treatment, early RX is essential, right? Essential, early treatment, essential. What is our first line? What is our first line? The CML. What is this case? CML, 95% of the cases will show what? Philadelphia chromosome. So what is our first line? What is our first line? Imatinib. Imatinib. Now look at this, guys. 95% of the patients show the Philadelphia chromosome in CML, right? And for that, we have a very successful star drug, imatinib. Imatinib. So what does this tell you? If the Philadelphia chromosome is positive in CML, what does that tell you about prognosis? What does that tell you about prognosis? Good prognosis, right? Good prognosis. So this is the important one. Don't mix the two up. Philadelphia chromosome, it being positive in ALL is bad. In CML, it is good. It is good. Okay. Right? Why it is bad in ALL, we don't have a good explanation, guys. But what I want you all to remember, if you all remember one of the two, it's enough. What I remember personally when I'm studying is that 95% of the patients show PH chromosome in CML, and we have an absolutely good drug against it. Therefore, prognosis is good, right? If the PH chromosome is positive, right? It's not the actual underlying mechanism, but that's more than enough if you all can remember, right? Okay, these are the things about CML. Then we'll come to AML. What do I want you all to know here? AML again, guys, 40 to 60 year age group, 40 to 60 year age group, right? Right. Then what did we say here? If we look at the blood smear, right? What will you see a special feature in the blood cells, within the blood cells? What do you see? Huh?
Our rod.
Yes, our rods are seen, and that is, guys, myeloperoxidase positive. Myeloperoxidase positive, and it can give rise to DIC. DIC. These two, if you can remember, it's good, right? Then for AP, the subtype APML, almost always DIC, almost always DIC, and the treatment is what? Retinoic acid, vitamin A, right? All trans retinoic acid or vitamin A, right? Vitamin A. Okay. And then another thing we mentioned about AML, guys, right? Remission maintenance often not required, right? Remission maintenance often not required. Okay, that's it I want you all to know for AML. Then come to CLL, guys. CLL, what is the usual age group? Huh? Chronic lymphocytic leukemia. Greater than, most of the time greater than 65. It is the most common adult leukemia. Now here I forgot to mention that, guys. This one, ALL, is what? Most common childhood cancer, actually, not just the leukemia. Huh? Childhood cancer. Huh? CLL is the most common adult leukemia, right? In the smear, in the peripheral blood, what is the characteristic finding? What is the characteristic finding?
Smudge cell.
Smudge cells. Excellent. Smudge cell, right? Now, this is what did we say? This is a lymphocytic problem. The leukemia, the malignancy is within these, not the fully differentiated ones, not the blasts, somewhere in the middle. So what did we have, right? The problems we had, one is hypogammaglobulinemia. The other one, right? Autoimmune activity against it. So autoimmune hemolytic anemia, due to the cross-reacting of the autoantibodies produced, they can cross-react with RBCs, giving rise to warm type, warm AIHA. Then another thing important in the blood, CD5 positive B cells. CD5 positive B cell. It is usually a T cell marker, but for some reason, in CLL, right, we can see this on the B cell, right? Here, guys, RX not always necessary. Treatment is not always necessary, right? Treatment not always necessary, right? Okay. Then, guys, the Richter transformation, I don't want you all to remember. If you all can remember, just remember, but very low yield, very rare and very low yield. Just that it can go into a lymphoma, right? A diffuse, a large B cell lymphoma, not very essential. If you all can remember these and differentiate these between these four, you all are good to go for MBBS. More than enough, right? Okay. So now, guys, I have put some questions, right, in your skeletal notes. We are not going to do them now, guys. What I want you all to do, try them after the class, tomorrow, day after, whenever you all have free time. Try them and send me the answer. Guys, I want you all to make a small edit to one of the stems, right? One of the stems, go to true or false. Yeah, question number 4. Here, prednisolone, I cut this can be used, just cut it. Just put prednisolone is only used for remission consolidation, right? Just put that one there and just try these questions and send me the answer. Now we have done, guys, 99.9% of everything in these questions. There are some subtle points that you all can learn from these questions, right? So what I want you all to do the questions, send me the answers. So what I want you all to do, first make a message. When you are sending me, send it on WhatsApp, right? Put SBA and put the question number 1, 1, 2, 1, 3, 1. And then for the true or false, guys, true or false, just put the message, question number, and just put TF, TF, TF in that order, in the A, B, C, D, E option order, put the TF, 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 and send the answers to me, right? Okay, if there are any mistakes, don't worry, I will teach it to you all over the phone, right? If there are any confusions, right? Just make this edit here, right? Right. Okay, guys. So that's about it, right? For leukemia. Now I know a bit of a problematic chapter. No nice flow of information. This leads to this. No, nothing. From out of nowhere, this translocation, this causes this. That's cannot help, guys, right? I want you all to try. Davidson's, Kumar and Clark, guys, no problem. You all can read, no issues, no issues. Harrison's, when you're reading, be careful, right? So I have done the reading for you all, right? So I'm giving you all the fair warning. It's a little bit complex. Actually, not a little bit, it's a bit too complex, right? Unnecessary. If you all want the information, you all can go there, but even there is a lot of unknown things that are still being researched, right? Davidson's, Kumar and Clark, go ahead, try reading them. Actually, you guys have to read those books. So Davidson's is a little bit more elaborate, guys. So what I usually do when I want to study a chapter, I will first read Davidson's, and then I go to Kumar and Clark, because Kumar and Clark is much more compact. It's a sort of a summary form, right? Okay. So that's about it for today's class. Did everyone understand? Give me a thumbs up. Show me your face. There are only 4 faces visible. Show me your face. Good. Thumbs are going up. Right? Okay. So this is it for this module, guys, from me. Right? Shan will be doing the Hodgkin's part for y'all. Sorry, Hodgkin, non-Hodgkin, the lymphoma part. Right? So I will see you all again in a upcoming module. And the restream will be announcing it next week. If you all missed any sessions, you all can cover them up. Right? Okay, so that's about it. Try the questions, send me the answers. If you all have any confusions, you all can ask me, right? Whatever we know for the MBBS level, we can discuss. Okay, that's about it for today's class. See you guys again in an upcoming module. Right?
Thank you.
No problem.
Thank you so much.
Right, see you. Right, you're welcome. No problem.